Good evening, sir.
Good evening, sir.
Hi, hi. How many registrations we have?
Sir, 1243.
Okay. எல்லாருக்கும் வந்து அனுப்பிச்சிட்டீங்களா இது லிங்க்?
எல்லாருக்கும் போயிருக்கு சார். லிங்க்கும் போயிருக்கு, ஈவன் மெயில்ஸ் ஆர் கான்.
இங்க ஃபேக்கல்டிக்கு ஒரு வாட்ஸ்அப் அனுப்புங்களேன், saying that வந்து this is the link for the audience. You can please
No, faculty link is separately sent. Faculty link will not be.
கேக்குறியா ரவி நான் சொல்றது?
Sir.
Send the audience link to the faculty saying please share it among those who you want to come into the meeting.
Okay.
Here is an audience link to share with your contacts. புரியுதா?
Yes, sir.
WhatsApp lamchapo.
Sure, sir.
Please log into the faculty through the faculty link. Faculty link this link is for audience. You can share. This is an audience link. You can share it with the this. இப்போ live ஓடிட்டு இருக்கா என்ன?
இப்பதான் enable பண்ணிட்டு இருக்கேன் சார். I'm just making it live.
No, don't make it live. Why should you make it live now? 550 க்கு பண்ணுப்பா.
Yes, sir.
டெஸ்ட் பண்ணி பாத்துக்கோ.
அதான் பார்த்துட்டு இருக்கேன் சார்.
Ravi, or Sanjay sir wants delegation link because he wants to log in as a delegate.
I'll send it.
Yeah. My faculty link. No, why should he come as a delegate? எனக்கு ஒரு delegate link அனுப்பு, நான் பார்க்கட்டும். I mean
Sir, I think Dr. Asta Joshi has joined. She will do the MC, sir.
If she wants to. Asta, are you going to be the master ceremonies, or how? Or do you want me to do that?
Sir, so I'll be introducing, yourself, and I'll be introducing all the chairpersons before every session is about to start. So, if in addition to that, if you would want me to do anything else, let me know.
No, we're fine. We're fine. I think that's fine. But what we need to do is, keep to time, so everything has to be very crisp. You don't have to go through everyone's full introduction. Just
Yes, I'll stick to the timelines. We'll keep it very brief.
Yeah, just to run through Dr. Asta, we have only the minimal this thing CV. I'll show you that. Actually, just let us go through that so that it will.
Okay.
See, this is what we have got. First we have got this thing, the topic, and then we have a introduction of the chairperson or moderator.
Yeah.
Only this information.
It is so brief that he has even removed senior from my title. Good. No. Just be. This is the right way to do it. Let's do it. Quick.
Yeah.
Okay, so the slides I have, they only have the introduction of Dr. Krishna sir, and then
No. You just introduce me, and I will introduce.
Yeah.
yeah.
Dr. Krishna will introduce others. Okay.
Yes.
People should know.
Hi, so should I share my screen, or this screen will only while I'm introducing, or this will do?
No, we are sharing the screen, so you don't have to do anything. Okay, just you have to introduce them. That's
Yeah,
enough.
that will do. Okay.
And one more thing, actually, I'll be, if any questions are there, then I'll be posting it here. So those questions, if any delegates ask those questions, if it is relevant, you can ask the chairperson or moderator to take up those questions.
Okay, fine.
Yeah, because we may not know actually which is relevant and which is not relevant. That is why.
Right.
Sir, good evening, sir.
Hi, Vijay Bhaskar. Good evening.
Good evening, sir.
Hi, Vijay Bhaskar. Hi.
Hi,
Good
sir.
evening,
How
sir.
are you? Hi, Shankar. How are you?
Very well, sir. Thank you. Nice to see you, sir.
Hey, new dignified professorial look. I haven't seen you with glasses before.
Ellame vandiruchu, sir.
Welcome to the club. Dr. Murthy is also joined. Sir, welcome, sir. Sir, you're muted, Dr. Murthy. Dr. Murthy, you're muted.
Can you hear me?
Yeah. Yes, sir.
Hi, sir.
Thank you so much,
Good evening.
Krishna. Hello, Reddy and Jay Bhaskar Reddy. And thank you so much for getting all of us together.
Right. Dr. Murthy, did you give your request for the dinner?
Yeah, but you given in time. I have no dinner at home. After the meeting, I have to starve.
Sir, it is on the way, I guess. Actually, it's supposed to reach you in another 20 minutes.
No, don't worry. I know how efficiently it's done. Don't worry. I'm just joking. And thank you so
Chennai
much.
Taj lendapa. Chennai is coming from Taj.
Chennai Taj linda auto.
Chennai is coming from Taj.
Yes, sir.
Dr. Anjali, good evening. You're muted, Dr. Anjali.
Good evening to everyone.
Once here, I think we have another 8 minutes or 12 minutes actually. Good. It's good for everyone to meet. How is Pondicherry, Vijay? It's come down or still there?
Come down, sir. Think back to normal, almost OP and all.
I think we should let our guard down. Same thing happened in the first phase, a couple of months.
Definitely, sir. Definitely.
Yeah, with the Delta variants and Delta plus, and we should be extremely careful.
I think people are predicting third wave somewhere in September, October.
Yeah. Second wave, was quite hard on people. Maharashtra, Delhi especially.
Yes, sir.
You see people getting into problems, getting to ICU without oxygen. It was pathetic. And here also, probably better in Pondicherry, in Chennai, people were so desperate. Every day I used to get 2 or 3 phone calls. Somehow get me a bed in some ICU, get me an oxygen bed, whatnot. And worst was, everyone was allowed to take care of a COVID patient. And one patient admitted in a private children hospital. The daughter the patient rings me up and said, somehow do something. I don't know, in a pediatric hospital, convert to a COVID center, how they would be able to manage, no protocol fault, each was doing their own thing. I think
Madam, good evening, madam.
Hello, Dr. Vijay.
Yes, madam. I think sir got disconnected, I think, Dr. Murthy, sir.
Yeah.
OP la paathiட்டு இருக்கீங்களா சென்னையில?
Chennai, it's now our admissions. We are having some few cases here and there, but our negative beds have increased now. Positive ICU is less occupied, so coming back to now.
Okay, non-COVID.
Non-COVID beds.
Murthy, இப்ப என்ன beach house இல்ல சென்னையா?
I think sir's line got disconnected. Huh?
He's back. But his thing is very bad. Sir, சென்னையா இல்ல இதா சார் இங்க மாக்கமா? கேக்கல. Just send a reminder to Dr. Prem. He's starting.
Yes, sir, I just spoke to him, sir.
He's not in some trek.
He's revising everything.
Revising, huh?
The call panta.
The less the evidence we talk, the better. In fact, what we'd like to hear is how people practice.
Yes, sir. Prem, login பண்ண கூப்பிடுறாரு sir. Okay. He's joining, sir.
You see patients on Sunday, Vijay?
Yes, sir. Sunday morning.
Yeah, old style. Sunday morning.
Sir, appointments have become so much, we are not able to handle.
Get a partner. I think it's time.
I put on assistant doctor now. Especially this post-COVID diabetes, there is just too much. Because at the time of discharge, they say, you go back to your doctor and manage your diabetes. And all of them are coming 300, 400, like this sugars.
I don't know why they extend the duration of steroids. I think that is the question. Many of them are sent on, see, it's less than 7 days. You just stop the steroids. Why are you tapering steroids? I'm not sure. There are some recommendations to use just inhaled steroids in milder patients, but everyone gets 8, 16, 32 milligrams of prednisolone. Delhi lala on the 32, 64. See, I see some online consults from Delhi. 64 million during the height of the Delhi pandemic. They were just running out of doctors. I've seen some online 64 milligrams of prednisolone and home. And many of these are very old people.
Actually, in some of these patients, those who have more than 40% lung involvement, they seem to show signs of organizing pneumonia. They say that's an indication. The pulmonologist was saying that that's why they extend the steroids for another 2 weeks after discharge, because they don't want that. Once it starts, it just progresses. The organizing pneumonia, which occurs after the onset of infection. So they are extending those steroids by another 15 days, and then they reassess them in the 3rd week, and then decide. They do that 6-minute oximeter test and see.
Inhaled steroids don't work. Using it through
budesonide, they are doing it only for home quarantine patients with cough, or just home quarantine patients. But those who are coming to hospital with hypoxemia, they're just starting on steroids. I think North, they were using more of dexamethasone also. Like some patients online, they were saying they were just sent back from casualty, asking them to take the dexamethasone at home. So there are no beds.
Phones. Ravi, we have a live stream.
Yes, sir, it is ready. We are live.
Why don't you put up the whole program on the screen so that people will join in?
Prem has joined, sir.
Welcome, Prem.
Sir, good evening. Good evening.
Hi.
Yes, sir.
Hi, Prem.
Prem, change your name. Your name is Pavitra.
Pavitra. Yes. Yeah.
Children using
Online lessons, yeah.
I was in a meeting where somebody was called X name 5B. and children will change the DP and everything. For many years, I work with I used to work with the Medical Council of India, and I work with the NFC. So I used to get calls from the MCI saying, "What is that picture of a woman on your DP?" I said, "What picture?" My daughter had changed that Google. She was a big fan of that Sita serial when it was coming.
Okay.
So she had changed DP to Sita. And I used to get, who is this woman that's on your DP? Asta, you want to take over? Asta?
Sure, sir. Sure. Are we ready to go?
I think we are hearing echoes of you, so you may want to use.
Okay, wait, I'll just probably mute and then unmute again. Is it better? I hope it's slightly better now.
No, madam, sir, echo is there.
What is there? Okay, what I'll do is I'll try using my headphones or something. Maybe that will be better.
Asta, just wear a headphone, Asta.
Yeah. I'll just get just.
Sir, good evening, sir.
Sridhar, good evening.
Welcome, Sridhar.
Yes, sir, good evening, sir. Thank you.
How are you? Things are fine in Madurai.
Yes, sir. So far, no problem. Now settle the case are well settled.
Everyone looks brighter.
Hi, am I audible now?
Very, very bad, Asta.
Very bad. Okay. So is this better or the one before this?
I think you dunked your phone or your laptop in a pool of water.
Wish I could, I don't know, help that with that.
I think let's go ahead and start, and then you can come back to the second session and by the time you can log in back.
Okay, fine. I'll do that. Okay.
Please start.
Krishna sir, you can start off, sir.
And Asta can start. Good evening, everyone. Thank you for joining us today on this thyroid update. This is a program that we do in Chennai every year. Was a very popular program, and in fact, in 2015, when the rains were big, I remember that it was pouring outside, and we had 300 plus people in the hall. And that was how popular this program was. And consistently through all these years, this program has been created and supported by Abbott, but never once have they chosen either the talks or the speakers. I've been privileged to host this program for so many years, and it's my proud privilege to bring together my wonderful colleagues from Tamil Nadu into this program. Each endocrinologist here brings in a wealth of information and, more importantly, wisdom that each of you who are listening to this and participating in this can take back and include in your practice, know when to do what and when to refer and when to interpret and do this. The first, my thanks to Abbott for bringing this program. This program is also powered by Clinic Tech, which is a company that I'm involved in deeply. Clinic Tech brings in the technical expertise. It's also helped create a electronic medical record that's cloud-based, that is preferably used for endocrine and diabetes practices and cardiovascular practices in clinics. So with this brief update, let me bring in the first one. Let me introduce the first speakers. Ravi. So the first will be a clinical case seminar, the medical management of thyrotoxicosis. This is for 40 minutes, and followed by and can I introduce the participants, please? Next. So we have Dr. Vijay Bhaskar Reddy, a consultant endocrinologist in Puducherry. He is the president of the Puducherry Diabetes Research Forum, member of the Endocrine Society of Tamil Nadu and Pondicherry. More importantly, he successfully conducted Trendo-2020 digitally and had a record participation. More importantly, a very, very down-to-earth, very, very astute and wise clinician, and that he brings up. Next one. Dr. Prem is the person who has taken over the mantle from both Dr. Murthy and me in Salem. Pretty much is the king of Salem. Has a fabulous practice, very, very practical. So you notice this theme of practical, and speaking of practical, can I have the next one? Dr. Anjali Satya, who is in Polo Specialty Hospital and Vijaya Group Hospitals, Chennai, very lucid, very to the point, and brings in the clinical experience that should make this program well. Can you stop sharing? I'll share my slides. Deepa, we're supposed to stop at 6:40, right?
Yes, sir.
Okay. Can you hear this? Okay. So we all have conflicts of interest for this particular talk. What I'm also going to allow is, we have an extended faculty here who have joined us right from the beginning, and we're grateful to them. And anytime they feel that they need to come in with a comment or a question or a clarification or a controversy, please do. My one request to each of the speakers is let's keep this to the point and brief, so that we can go through the whole thing and allow questions from the audience. The audience are viewing it from a YouTube broadcast, and Ravi will post these questions to us. Correct, Ravi?
Perfect.
Okay. I'm just going to, because we don't have a talk on interpretation of thyroid function tests, just remember that in endocrinology, we measure hormones in pairs. On the y-axis here is TSH, on the x-axis is T4. And the relationship between them is reciprocal. And what we're going to do is to deal with this condition where the free T4 is elevated and the TSH is suppressed, which is primary thyrotoxicosis. Remember, there are other conditions where the free T4 is elevated and the TSH is also elevated, which could be either pituitary thyrotoxicosis or resistance. And of course, at this end of the spectrum is hypothyroidism. When confronted with this particular set of values, if the free T4 is high or TSH is suppressed, this is primary thyrotoxicosis. If the free T4 is, it should be elevated, is elevated, but the TSH is, and the free T4 is normal and the TSH is suppressed, That is the only reason to get a T3, increase its T3 toxicosis. If it's normal, it's subclinical thyrotoxicosis. We will not be dealing with these entities today. We will primarily concentrate on this. And even in this, we will be talking only about Graves' disease, which is primary hyperthyroidism. So let me present this patient. It's a 26-year-old woman, presents with palpitations, a 6 kilogram weight loss, and a prominent stare. She has increased frequency of bowel movements. Symptoms present for 3 months. Menses regular and scanty. She's recently married and does not intend to start a family. Pulse is 100, blood pressure is 130 by 80, weight is 56 kgs. She has lid retraction with mild proptosis, but there is no diplopia. There are fine tremors seen. She has onycholysis, which is a lifting of the nail bed. She has a diffuse soft to firm thyroid, enlarged and palpable. Some lymph nodes are seen in the cervical chain bilateral. Vijay, I've corrected the lab values. The free T3 is 6.5 picograms per milliliter, which is elevated. The free T4 is 4.6 nanograms, and that is elevated. The TSH is less than 0.01. So let me start with Dr. Anjali. Dr. Anjali, you want to take the first question. From the clinical presentation, what is the most likely diagnosis? And I also want you to take the second question, where are the clinical features sufficient enough to confirm the diagnosis?
I think when we, here the symptoms are very classic of a thyrotoxic patient, and what is most common should be our first differential. So I think definitely Graves' disease is the first differential diagnosis, and that is only likely to be present here. There are certain clinical features which would actually be in favor of the diagnosis of Graves' disease. That is, she has mild orbitopathy. Proptosis, you mentioned mild proptosis. So presence of eye signs is one. Second would be presence of a soft goiter. Usually other autoimmune thyroiditis, we see a firm gland. So a soft pulsatile gland, presence of mild orbitopathy, I think is a very strong clinical indicator here towards the diagnosis of Graves' disease.
Can I have a follow-up question with you?
Yes.
Are there situations where you think, that the clinical features are so strong that I don't need to do besides a thyroid function, a further diagnostic test? Do these situations occur in clinical care?
Yes, I think presence of, if you have a dermopathy, pretrabeal myxedema, orbitopathy, as I mentioned, and also maybe thyroid acropathy. So if you see a digital clubbing, it's a very classic sign of Graves' disease, which cannot occur in other conditions.
What about the lymphadenopathy? You think this
lymphadenopathy is seen even in Hashimoto's thyroiditis. So we do see mild lymphadenopathy. It could be a non-specific feature, but it is. So I don't think that's a very specific marker.
The other panelists, any brief comments about what Dr. Anjali has said? Anything else you want to add?
There are some studies where they have compared clinical diagnosis of Graves with a laboratory biomarker-based diagnosis, and they found clinical parameters might be wrongly diagnosed in 30% of the cases. So you might misdiagnose subacute thyroiditis with these soft clinical markers. So if there is active thyroid disease, there is no issue. If it is a mild proptosis, which actually can be mistaken or missed by some people, properly measuring the proptosis level and be assured that the other signs, if it is present, strong active thyroid disease can be I'll say that it's a strong for making diagnosis of Graves' disease. Mild proptosis, sometimes we might miss, or we might overdiagnose Graves.
Okay. Any other comments? So I think one of the most significant feature that I would add is a duration of illness. Right? When you have long duration of illness, it is almost unlikely to be just thyroiditis. But let's take you, Prem, on this. So what is your diagnostic test of choice in this patient?
Okay, sir. As I already told, Graves' disease has got a diffuse goiter. And this diagnostic test of choice can differ with other endocrinologists. Depends upon where you practice, whether radioiodine uptake scan is available in your place or not, and that is there. So in my place where I practice, where there is absence, there's not available radioactive iodine uptake scan, I used to do ultrasound neck. And if it is a diffuse goiter, it is for a diagnosis of Graves. If there is a multinodular goiter, still it can be Graves. In presence of multinodular goiter, I'll be more happy in referring this patient for a radioactive uptake scan. And during the months of September to February, where the occurrence of cervical thyroiditis is high, I will still be happy in referring this patient when there are other clinical features, rapid onset of symptoms, less than 1 month duration of symptoms. I'll be happy in getting a thyroid uptake scan done. And nowadays, what has happened is various investigations are available. TSH receptor antibody is available.
Let's get to TSH receptor in a minute. So,
later,
okay.
yeah.
But do you use regularly to diagnose?
Ultrasound neck
is what you do. Vijay?
Sir, this case was clinical features are typical of Graves' disease. So, patient had, as Madam told, patient has diffuse goiter and without any clear-cut nodules palpable with orbitopathy and acropathy. I think clinically diagnosis of Graves' disease is made. So, in this case, we can do a baseline TSH receptor antibody. If it is positive, that will confirm the Graves' disease and will also have a baseline for further management.
Hey, Anjali, people are talking about TSH receptor antibody as something for this patient. Do you think that a routine TSH receptor antibody to confirm the diagnosis of Graves' disease is something that you would do?
I think, Dr. Krishna, guidelines is one thing, and practical practice, what we encounter in practice is a different thing. Now, availability of TSH receptor antibody may not be. I'm not sure about all endocrinologists. I work in a city where it is available. So I think I can go by the guidelines and do a TSH receptor antibody. Probably
for a diagnosis.
No, it's not required. I think for follow-up, it is more important, especially at the end of 12 months or 18 months. If the diagnosis is clear-cut, I think what I would do is an uptake scan. Because even nodularity can be missed on clinical examination. So I think when we have facility for an uptake scan, we can go ahead with an uptake scan. And that will almost like there will be a rapid uptake and then a washout.
So can you also comment, can one of you comment on the technetium uptake? Because I think Prem already talked about radioiodine. Can someone comment on the technetium uptake and scan?
It's a cheaper test and it's easily available and you have the results within 4 hours.
So do you do a technetium uptake or a radioiodine uptake?
Ideally, iodine uptake should be done, but I do with technetium scan. Because iodine-131 is not freely available. It has not been available for last 1 year. They had shipment issues. So I have been doing technetium uptake scan.
So quickly to summarize where we are right now, the reason that you want a confirmatory test is to exclude low uptake thyrotoxicosis. This low uptake thyrotoxicosis states are basically conditions which are self-limiting. And the scan helps you distinguish between Graves' disease, nodule, and a multinodular goiter. Now, recently, people have started using thyroid receptor antibodies to sort of confirm Graves' disease. It's not a gold standard test and probably not required for the diagnosis, but many people have used it as a baseline, as Dr. Vijay Bhaskar Reddy and Dr. Anjali Satya and Prem said, that as a baseline in patients whom they think that they have Graves' disease. Remember that there can be false positives and false negatives. This is a slightly older slide, but remember that the negative predictive value for Graves' disease is around 70% in this. So clearly, it's still not as confirmatory as a radioiodine uptake. I still do radioiodine uptakes, but I'm fortunate enough to have it done. But you can do clinical and remember that the pretest probability determines the post-test probability. So in someone in whom all the signs are present, a test is probably not even required, but most of us would do an uptake and maybe a TRA. But that's not what we're here for. We're looking at the medical management. So I'm going to start with Vijay. So what are the treatment options for this particular patient? How do you discuss these options? And in your view, what is the most appropriate option?
There are 3 treatment options for thyrotoxicosis due to Graves' disease hyperthyroidism. First is medical treatment with antithyroid drugs. Second is radioactive iodine ablation. And third is surgery. So this case is a young lady, 25-year-old lady, recently married. So, but the history told that she was not planning for pregnancy immediately. These are the salient features in this case. So this case, the elevation of thyroid hormones is mild, moderate. They're not severe thyrotoxicosis. So I would go with the initial treatment with medical treatment with anti-thyroid drugs. So with the hope that the chance of remission is possible in this case. There is 50% chance of remission over use of anti-thyroid drugs for up to 1.5 years. And there is a chance of remission by using anti-thyroid drugs. So that's why I would go for anti-thyroid drugs in this case. Radioactive iodine ablation, we will discuss that the patient should not plan for pregnancy within 6 months at least after radioiodine ablation. Although she's not planning now, but after marriage, she wants to plan immediately after a few months. It may be difficult with radioiodine ablation. Straightaway surgery will be not a good choice. So I would go with anti-thyroid drugs as initial treatment.
Thank you, Vijay. I'm going to bring all the three panelists in this. When I first landed back in India, I almost 50 to 60% of our patients would initially go for I-131 ablation, and it also sort of determined, where you trained, whether you trained on the east side or the west side of the coast. But what is interesting is that over a period of time, that people have started moving more and more towards thionomides. Why do you think, and I will let all three of you, maybe I'll start with Prem and then Vijay and then Anjali. What has been the change in the last few years? And Vijay, your voice apparently is breaking, so you need to check. Okay, so what do you think has happened in the last few years?
Yes, sir. So there are a lot of data which has come, which actually compared the outcome of people who had underwent a radiation ablation and also people who were on long-term medical management. And the outcome and the follow-up data are actually similar. There's no any definite advantage by giving a radiation ablation at the first stage. That is one. Second is the quality of life and also the cost effectiveness which was analyzed. People have found that in those who had underwent a radiation ablation, they gain weight. And hypothyroidism is difficult to control because they require higher doses. And many of them are not on target and even on regular follow-up. And that is there. And the cost analysis, when it was done, it's almost similar with a long-term medical therapy with anti-thyroid drugs. In the case for anti-thyroid drugs, these people were on low dose of anti-thyroid drugs, say 2.5 and 5 milligram for a prolonged period of time with well-controlled thyroid function. And usually the side effects occur in the initial part of exposure, say 6 months maximum. And after that, they are safe at the lower doses. And they require a lower dose and euthyroid state is continuously maintained. And that's why the analysis and all the other data which has poured in actually says both are equally effective in the long run. And that's what made many of us to rethink our strategy. Even the guidelines say that.
Anjali, you want to add to this?
I think we have observed some patients who have been on years together on thionomides doing extremely well. Now, what we see in the management of Graves' disease is that it's only in the initial 1 year or so, or maybe 2 years, that the disease fluctuates a lot, and there is a lot of fluctuation in dosing. As the years go by, the disease becomes more stable. You use lesser and lesser dose of thionomides, which are fairly safe, and we can even increase the interval of follow-up. They don't need to come every 2 months or 3 months. And we have people who have been taking thionomides for almost 15 years. The disease burns out and they become hypothyroid. So safety-wise, of course, it has stood the test of time. Second, radioactive iodine, yes, in this scenario, I think in this young lady who is married, not planning kids, this should be an opportunity to counsel her. We have to tell her all the pros and cons. Radioactive iodine therapy is going to just make her hypothyroid within a span of 3 months. Whereas when you use anti-thyroid drugs, you are actually achieving a euthyroid state. And you're doing a dose titration and achieving a euthyroid state rather than rendering them hypothyroid. Also, there is a transient increase in trap titers following radioactive iodine therapy. So if this lady doesn't follow contraception and she conceives, so these are issues which I think we need to consider. We have to take it as a case-per-case basis. And I think medical therapy is a very safe, easy to manage option for both patient and doctor.
Jay, you want to close this?
So traditionally, there has been a difference in treatment options between USA and Europe and Japan. So Europe and Japan mostly they were for thionamide therapy, whereas in USA they used to prefer radioiodine therapy. But what we have been doing in India is from initially itself we are more for initial therapy with thionamides, and for relapse we consider definitive treatment with surgery or radioiodine therapy. But now in US, as Dr. Anjali Madam also told, so with the recent evidence of the long-term safety of thionamides, so more and more people are going for long-term therapy with thionamides and initial treatment with thionamides with the hope of remission, especially in a case like this, a young lady with a small mild goiter and mild elevation of thyroid hormones, the chance of remission is very high.
Thank you very much. Let's move on. So let me bring in Dr. Anjali on this. So Dr. Anjali, what would be a choice of drugs? Generally, what is the duration that you use drugs in clinical practice? We can talk about titration in a while, but what would we choose? Maybe you could also talk about methimazole versus carbimazole.
So I think the choice of drugs is thionamides. And among thionamides, I would choose methimazole because it can be given once a day. And methimazole is the active metabolite. The carbimazole gets converted to methimazole. So we can use it as a once a day dosing. That's the advantage. It can be given and it's easy to the compliance rates also can be quite good. The dose titration is usually done.
We can come to that in a minute. So what is your starting dose?
For this patient, I think the starting dose would be somewhere between 10 to 15 milligram once a day of methimazole. That would again depend on the baseline thyroid function. So the dosing of the choice of dose depends upon the initial levels of T4.
Prem, do you do anything differently?
Sir, just a minute. Yeah. So I use carbimazole and methimazole equally. Depends upon where the patient comes from. If it is city, methimazole is widely available. In the outskirts, carbimazole is widely available. I start the level of drugs depending upon the T4 level, free T4 level. And if it is high, I start with 20 to 30 milligram. And if it is just 1.5 to 2 times, I start with 10 to 20 milligram. It depends. And also depending on the size of the goiter, the symptoms of the patient, I consider all these factors and decide the dose and also the frequency of follow-up.
Just a follow-up question. Do you start with once a day or twice a day?
Sir, both carbimazole and methimazole, I start once a day. Though carbimazole has got a short half-life, but tissue half-life is more. So I use once daily only both the drugs. And it's easy, compliance is good. And up to 30 milligram can be easily given methimazole once daily. When it goes above 40 milligram, with carbimazole, I split it into 2 times.
Vijay, anything different that you do?
In this case, the T4 level, the free T4 level was around more than 2 times elevated. So I would use methimazole 20 milligram per day. I would prefer to use twice a day in the initial time because the thyrotoxic phase, there can be rapid metabolism. So initially I would use twice a day, and for follow-up I would use once a day. I will start with 10 milligram twice a day and repeat the thyroid function test after 2 months. In case I want to use carbimazole, the equivalent dose is 6 milligram methimazole is equal to 10 milligram of carbimazole. So I would use 30 milligrams of carbimazole initially. So as Prem told, in the peripheries, methimazole availability is still an issue. So I would prefer to use carbimazole if the patient is coming from outstation. And in cities, I would prefer to use methimazole.
So other than the fact that it's a pro-drug, are there any differences in the outcome in terms of recurrence or in terms of remissions with the use of either drug? Or are they just the same but different? One is a pro-drug and the other is not.
So I think they have been used interchangeably only, sir. It looks like evidence is it's just carbimazole is a pro-drug which gets converted to methimazole.
right. So people can actually use either, isn't it? Which they're comfortable with.
Yes, sir.
So do you routinely start beta blockers in all these patients?
So beta blockers in the initial phase, the thyrotoxic phase, when they present, I would start beta blockers because they provide quick symptomatic relief. And studies have shown that if you give only antithyroid drugs without beta blockers, the heart rate reduction and symptomatic relief is lesser than when combined with beta blockers. So beta blockers I would use. I would ask for history of asthma. If there is history of asthma, I would not use beta blockers. Or I would use a highly cardioselective beta blocker like bisoprolol or metoprolol, or we can use a central calcium channel blocker like diltiazem. We can use small dose.
I think
Okay, so I use a lot of diltiazem. Yes.
I think one thing is that whenever we are treating thyrotoxicosis, the patient symptom relief is the topmost priority, and beta blockers work faster compared to the thionamides. For the thionamides to work and exert its action, it would take about a few weeks' time. But beta blockers give symptom relief in a week's time itself. They stop getting tremors, the palpitations subside. So I think that is more important.
Dr. Sriram had a comment. Dr. Sriram?
Yeah, it was actually the choice of therapy. I had a small comment. In addition to what our esteemed colleagues who mentioned about the thyroid and Graves specific options, like, when to choose medical versus surgical, the comorbidities, especially like recently we had at least 3 or 4 occasions where a patient with rheumatic heart disease and an atrial fibrillation, obviously, a radiation ablation, a permanent cure of hypothyroid will be, hypothyroid will be very easy rather than, fluctuating functions in them. Another lady with lupus, and that these drugs like propylthiouracil and carbimazole can precipitate or aggravate lupus. So it's not about the thyroid alone or the remission. We have to look at the overall thing in deciding. And osteoporosis, fracture, etc., where you need quicker control as well as permanent control, you have to choose radiodin and not go only by the medical. This is what I want.
Thank you. Also, for example, the patients who are on amiodarone and heart failure, I think you need a really good surgeon who will be able to do a block dissection without having much anesthesia. Excellent. Vijay, why don't you take this and continue? Should we measure the baseline TRAB in all patients before you start therapy?
So, baseline TRAB is not a must while starting treatment. But if the patient can afford, if we do a baseline TRAB, it's useful for us when we are going to decide when to stop the treatment. But not for the diagnostic purpose. The baseline TRAB will help us in assessing the initial baseline so that while stopping, it's more useful. So we can compare against the baseline.
Anjali, baseline TRAB?
Not for diagnosis. I think follow-up TRAB will
for
be
treatment.
much better.
When you start treatment, do you get?
I have not been doing that routinely, but now that this test is freely available, I've started using. So in the initial years, I was not using.
Prem?
Yes, sir. Actually, since the radioiodine uptake scan is not available, technician scan, I've been using this, and we do it at a less affordable rate, and it is of very good use in differentiating various types of hyperthyroidism.
But do you use it as a baseline for treatment? To look at remission?
Yes, sir. Yes, sir. Actually, the level of baseline level also predicts the duration of the therapy required by the patient and also the rates of remission. And for certain group of people who would like to know more about drug therapy, how long it will be continued, it definitely gives a lot of insight into the duration of therapy, the likelihood of remission. All those things are given by this test. In selected group of patients, I do basal.
Thank you very much. So this patient was started on carbimazole 3 tablets after food, and the basal TRAB was 24 units. 1 month later, the symptoms were suppressed. The TSH were stabilized. TSH was suppressed. Carbimazole was reduced, and then the next month to 10 milligrams per day. So this is where the patient was. Patient feels better. She has gained 2 kilograms and no tremors are seen. But if you notice, the TSH is going up to 4.2. Prem, what will you do?
Sir, this is a very short period where the patient has gone to a hypothyroid phase. And we know that continuous exposure to anti-thyroid drugs are very essential to alter the course of the disease, to suppress the antibody production, and also to have a good remission when you stop it later. In these kind of patients where they don't tolerate less dose of anti-thyroid drugs, many times when you stop, what happens? They again develop hypothyroidism. In these scenarios, when they require very less dose and they become hypothyroid, I start them on block replacement therapy. I give them small dose of thyroxine and I continue the anti-thyroid drug, and I follow up the patient.
What is the purpose? So just to sort of remind people, in 1992, when Amino first proposed block replacement therapy, he thought this was going to suppress the antibody production, but that did not happen, right? So you are only giving it for convenience and dosage, isn't it?
Yes, yes, sir. It avoids a lot of confusion in the patient that one time he becomes hypothyroid, you reduce the dose, they become hyperthyroid. The ups and downs happens in certain group of patients. And this particular therapy actually will give a smooth control and also follow up, and the patient will be symptom relieved.
Right, Anjali, you do something different, right? Can you talk about it?
I just reduce the dose of anti-thyroid drugs. I mean,
how low do you go?
I go to 5 mg alternate days and maintain on.
So that's 2.5 almost per day.
Yeah, that's right.
And but you haven't had issues with patients increasing their TSHs over a period of time?
No, because they come for regular follow-ups.
Okay. So how often do you follow them up?
Now, in this patient, it depends on the rapidity. I mean, it would depend on the patient. If you have a larger size goiter, a severe thyrotoxicosis, so initial follow-up is at 1 month, and then at monthly intervals. And once they are sort of settling down, then I make it once in 2 to 3 months.
Vijay, what do you do?
I do not use block and replace regimen, sir. I would do the way Madam is doing, Dr. Anjali Satya. I would go for 5 milligram alternate, 5 milligram followed by 5 milligram alternate day. I follow up every 3 months once.
Okay. The other question is, are there any patients would you consider stopping at 6 months and saying, okay, you know what, this patient probably doesn't require 18 months? Have you done that?
So if the patient, even with 5 milligram alternate days, by the time we do 5 milligram alternate days, they would have at least completed a year. So most often they will tolerate 5 milligram alternate days, they tolerate well. So if the TSH is going up, even with a small dose, then I think I would stop by 6 months.
Okay. So you don't, then you wouldn't think that everyone should complete 18 months?
No.
No, sir.
Okay. Okay. So remember everyone. So let's the summary. There are people who think that you need to have at least 18 months of care, and then there are people who feel, look, as long as the patient gets suppressed, the TFTs are going up, and it takes very little doses of thionomides to control them, then it's worth stopping the drug and seeing if these people remission or not. It depends on where you trained. It depends on your experience. It depends on your wisdom. There are really no studies that say one group is better than the other. Block replacement is an acceptable alternative on the other hand. And for example, especially in the pediatric group, where it has been actually shown that, it reduces patient visits, it maintains this thing. In the adult, no difference between the titration group versus the block replacement group. So this patient, because this patient comes to my practice, we added BRT, the patient was stable. My aim is to keep the TSH at the lower limit of normal. We'll sidetrack for just half a minute. Anjali, if this patient became pregnant, what would you do?
I mean, on a block replacement, I don't deal with it. So if I...
No, on your titration dose.
On my titration dose, I would stop the antithyroid drug. In fact, because she's so mildly hyperthyroid and requiring such a small dose of antithyroid, considering the fact that antithyroid drugs have teratogenic profile, I would consider stopping the antithyroid drug, because most of these patients, they tolerate mild hyperthyroidism well. So if we can, go through the first trimester without any antithyroid drug, well and good.
If you have to use an antithyroid drug, what would you use?
I mean, that would depend on the baseline requirement.
Let's say the patient is floridly toxic.
Floridly toxic, I would change it to propylthiouracil.
How many weeks?
I mean, if the patient reports just before planning pregnancy, even before pregnancy, or as soon as they report at the first antenatal visit.
Is there data to show, let me just push you, is there data to show that you should not get pregnant? I mean, I get this from infertility specialists all the time, asking to switch to PTU before implantation. But is there data to show that being on carbimazole at the time of implantation is not
No.
adversely affects outcome?
No. It's by convenience. If the patient comes to you saying that the patient is likely to get pregnant and they're going ahead with an assisted reproduction, you know that in next few weeks' time they're going to go for embryo transfer. So I think we can make a change then and there. It would depend on the case-to-case basis. Most of the
would it
time
also
patients
mean
come
longer
to-
exposure to PTU? Would it also mean longer exposure to PTU?
It might, yes.
So you need to get a balance. So just to summarize, PTU is not recommended to be used beyond 12 weeks. And therefore, the discussion that we are having is to see whether, how do we reduce the PTU exposure and what is right. So for the first 12 weeks, there is a problem with thionamides. I mean, especially carbimazole and metimazole, because of reported dysplasia cutis and other malformations. So, but PTU itself has so many issues to it that it's not recommended to continue beyond 12 weeks. So let's move on. So here is this patient at month 18 on TFTs. Because of the thyroxine, this is the TSH. But here is a patient who's completely euthyroid. There is a discussion on discontinuation. Would you just so let me bring in Prem. Would you discontinue, or would you do any more testing before you discontinue, or what else?
So the patient is on 88 microgram of thyroxine, and with a suppressed TSH, I would like to reduce the thyroxine dose in a phased manner. And when he completes 18 weeks, I would like to repeat his TSH receptor antibody to see if the drugs can be stopped. And so that will be my approach.
So in the interest of time, if the TSH receptor antibody is negative, yes, you would stop.
I will stop.
If the TSH receptor antibody is still high, would you continue the thionamides?
Yes, sir. So a level more than 3.8 or 4 actually has got increases for relapse within 6 months. So I would like
you would continue it for another 6 months?
Another 1 year at least. That's what the guidelines say.
Yes. Vijay?
Yes, sir. I would, if the TSH receptor antibody is positive, then I would continue for 6 months.
6 months.
But in this case, I would take off the thyroxine slowly.
Anjali, I mean, forgetting that this is block replacement therapy, what would you do? Would you measure a TSH receptor antibody before discontinuing drugs?
Yes, definitely. In Graves' disease, yes.
Absolutely. Okay, so I actually don't taper off the thyroxine. What I do is I switch them off to propranolol and stop. I measure the TSH receptor antibody, get the switch them on to propranolol and stop it for a month, and then see what happens. So we all have different ways of doing things, but each of these are...
Yeah, sorry to interrupt. I had one question. So if the patient is on a block replace therapy before getting pregnant, what do you do after they conceive?
Stop the thyroxine.
And what about the thionamide?
The thionamide, I would switch to a lower dose. Not this patient. I think this patient is sort of, I would be very careful, but I would take off both and just watch. And remember, symptoms are also important. And then you can actually, doing a free T4 within 5 to 7 days will give you, even though the TSH may or may not be suppressed, the thyroxine still will rebound. So if you really want to monitor such a patient, this is what you do. To be very honest, if somebody is planning a pregnancy, I generally do not do BRT at that time.
Yeah, that is what I wanted to ask. So if a woman is planning pregnancy in such a young woman, 28-year-old, would you start with a block replay? Would you consider that at all? Or would you go prefer a dose titration, which is much easier?
No, I use BRT because because one, it does is if the patient says, look, I'm not planning any pregnancy, then I would not. On the other hand, if somebody's on thionamides, I would tell them, go ahead and try to become pregnant, because I don't really, once, the first 1 or 2 months of toxicity is over, I leave them on the thionamides and tell them, go ahead and get pregnant. We will handle this. This is a patient who didn't want to be pregnant, so we use BRT. But of course, every pregnancy, as we know, is an accident, and that's what happened. Okay, so we asked this question, how long would you consider it? And I think everyone said, I think Prem said he will continue for a year. Vijay said 6 months.
6 months.
How many months would you continue?
I mean, is she still breastfeeding?
No, forget this patient. If the TRAB is more than 3 months.
Okay, I think we would consider for 6 months.
Okay, the patient was discontinued. Thyroid function tests have been normal in this patient. Just to close up quickly, How often will you follow this patient? I'll ask each one, just one word. Anjali, how often will you follow this patient and how long?
Initially, after stopping the drug every 3 months for 1 year.
And then?
And thereafter annually. I mean, I would ask the patient to maintain a weight record because that's a very sensitive measure for them to come and report to us. Graves' disease will be followed up lifelong. That is
I mean, that's the beauty of being an endocrinologist. You have patients for life.
So
Right. Vijay, I'm going to ask you the next question. If there is a recurrence, what would you do? Medical therapy, surgery, I-131?
So I would do medical therapy first, sir, in this case, and then I'll discuss the options of definitive treatment between surgery and iodine ablation, depending on our future plans of pregnancy. What are the patient's preferences?
Okay. Prem, last question for you.
Yes, sir.
What about using thionamides indefinitely?
Yes, sir. So the long-term use of thionamide has been well studied and it is safe at a low dose. Most of the side effects occur in the initial few years of its usage. So it can be safe to use, especially the agranulocytosis, everything happens in the short term only. And all the allergic reaction also happens within the first 3 to 6 months of its use. So at a lower dose, they are safe, provided they are monitored and at least 6 months interval, the patient should be on follow-up.
So have you prescribed lifelong therapy to anyone?
Sir, in the long run, many of them become thyroprodic. They usually become euthyroid. Later, they become hypothyroid or supplementing hypothyroid. It's unlikely that they will require it for 30 years or 40 years. Long run, they become euthyroid or they become supplementing hypothyroid.
Okay, we need to close. So we are already up by 3 minutes. Any quick comments from our other faculty? Any burning thing? And any questions in the chat box that we need to answer, Ravi? Ravi? Ravi, are there any questions in the chat box?
There are no questions.
Okay. Any other comments from our other faculty members here? Any quick comments that you need to make? Okay. So if there are no more questions, thank you very much. This has been first, you know, we really stressed out our panelists. We kept going at them and they just raised to the occasion and created what a wonderful discussion. That was not just about studies and you know data, but what they do in practice, which I think is what most people would like. So with this, thank you very much. I would appreciate all our faculty here, and thanks everyone for joining. Please participate. Ms. Dr. Joshi, are you there? Can we go on to the next session?
Yeah, hi sir. I hope I'm audible now. It's better.
Very
Great. Okay, so we'll quickly move on to the next session. Thanks a lot, sir. So for the next session, we have a very interesting debate, and the topic for which is, does tissue hypothyroidism exist and should it be treated? So that's the question, and it would be moderated by Dr. Muthukumaran. So before we start with the debate, just formal introduction of Dr. Muthukumaran. Sir is the managing director of the ARCA Center for Hormonal Health in Chennai. He's a consultant endocrinologist at the Fortis Hospital, Chennai. So over to you, sir. Take it up. We're all yours.
You are muted.
Muthu, you're talking to yourself.
Thank you so much. Good evening, one and all. It's my pleasure to be here. Thank you, Krishna, and thank you, Abbott, for the opportunity. We've had a wonderful Sunday, reading whole day because of Krishna. My wife is really angry with you. So we'll get that sorted. You're spoiled.
I try very hard, Muthu.
Yeah, so you have made it this time. So I've been on the computer since morning 7 o'clock. So
as a compensation, she doesn't need to cook this evening.
If you're paying for it, yes.
Muthu, the faculty dinner is being delivered. I guess you didn't check. We'll see.
No. Don't worry about it. We'll quickly move on. I've got two friends and colleagues and celebrated speakers in the state, Dr. Shankar Dandapani and Dr. Sriram Magadevan was a close colleague and friend of mine, here to debate this special topic, interesting but controversial as well. So we would look into all the possibilities and negativities of treatment in this particular topic, which is tissue hypothyroidism, whether we should acknowledge it or if at all, if we do acknowledge it, should we treat it at all? I will first invite Dr. Shankar Dandapani to put his case through before we ask Dr. Sriram Magadevan to talk across. Thank you.
Thanks you, Dr. Muthukumar. Good to see you again. Give me a quick sec. Okay, right. Is my screen visible?
Yes, Dr. Shankar. Yeah.
Right. Thank you. Right. Thank you for asking me to talk for tissue hypothyroidism. And I will start my session from a letter I received from one of my patients. And this was roughly 5 years ago when I was working at Blackburn. This is a young girl who is 18 in the first year of her university, who was diagnosed to have some suspicious nodule bilaterally, and she had a thyroidectomy. And it turned out to be a benign lesion, and ever since she has been on thyroxine replacement. So she come to the clinic regularly, and she been on a good normal replacement dose of levothyroxine, but she never felt happy. So she wrote to me a letter once. Dear doctor, ever since I had my thyroid surgery, I feel my life has been taken away from me. Before all this thing happened, I was a very bubbly, happy going, easy-going girl. But since I had this surgery and on thyroxine replacement, I never felt the same again. I wake up every morning feeling constantly tired, and I feel there is some sort of a mental fatigue. I could not think straight. I kept putting on weight. So I keep mentioning this to you in every visit, but you try and reassure me that everything is well. I feel that I'm being swept under the carpet. Is there anything that you can do to make my life better? I'm sure that most of us do have similar experience in treating hypothyroid patients. So a large number of our patients who is on a good replacement dose of thyroxine still don't feel happy. I wouldn't say everyone, probably 1/4 of our patients. They do have a lot of symptoms which are often non-specific. Feeling tired, easy fatigability, and weight gain, hair loss, and so on. Some people, particularly the village ladies from villages, they said they don't feel normal. They could not explain why. So what is happening here? Are we missing? So, but in reality, are we taking these things very seriously, or just dismissing these symptoms? In a busy clinical practice, where we see sort of 50, 60 outpatients a day, so do we have time to look at this, or this lady is crazy, we'll just get her out and get the next lady in? So because of the non-specific nature of all these symptoms, is there anything really going on we're missing, or is there any other coexisting problems that makes the things a bit difficult, and how do we manage them? So the question in front of us is, are we actually treating the patient or the number? Sort of 4 or 5 decades ago, before the availability of a good TSHSAs and a proper levothyroxine therapy, the physicians tend to treat the patient by the symptom, and they go by the symptom, and they have to use desiccated thyroxine, and the dose varies. I'm not saying that is physiological. It was a very tricky and difficult thing to do. And since the last 4 or 5 decades, they have these improvised TSHSAs and a proper thyroxine that made life easier. But instead of taking this as an advantage, are we just wholly relying on this one? I don't know how you guys practice. So every time I see a hypothyroid patient, even before the patient comes into my clinic, I will make my decision. Okay, this patient's TSH is 2.3. Yeah, let her continue the same 75 microgram of thyroxine. So sort of thing. And you ask them questions, most of them will be happy, but some still complain. So are we really listening to the patient's symptoms, and are we trying to get into the bottom of the problem? Or we just unsympathetically dismiss the symptom? Can these symptoms be explained by other comorbid condition, or is the real entity called tissue hypothyroidism exist? If it does exist, is there any real scientific rationale for the explanation? And if there is an entity like this, how do we measure it? And how can you address this differently rather than just a levothyroxine replacement? Right. In the olden days, we do have a lot of scoring system for tissue hypothyroidism. Initially, it was Believek's scoring system, and of course, it was modified by Zaleski eventually. So they score 1 point if the patient have this symptom, and 0 point for the symptoms on the right side. For example, they relied on the symptoms and signs of the patient. So if someone got diminished the sweating, they score 1. And if they sweat in a warm room or a hot summer day, they score 0. Remember, Believek practiced in Scotland. Okay? So it's a cold place. So they use this terminology like sweating in the warm room or a hot summer day sort of thing. And then if the patient has a hoarse voice, they get 1. Or if they speak in a normal voice or sing, they don't get any score. And paresthesia, if they have numbness, they get score 1. And if they're reasonably well, they don't score. So eventually they get 1 point for every symptoms like dry skin, constipation, increased weight, and impaired hearing. And the other physical line like slowness of movements, delayed ankle reflexes. I don't do any ankle reflexes in my clinic, right? Coarse skin, cold skin, and they eventually summarized all the scores. If someone got a score of 5 or above, then yes, they have ongoing hypothyroid symptoms, or they use a diagnosis and then follow up. If someone got a score of 2 or less, then it's probably non-hypothyroidism related, and between 3 and 5 is sort of a gray area. So this was the scoring system used in the olden days. And of course, some people still suggest that we should be following them. So what can be the etiology of the symptoms? As I said, vast majority of thyroid patients, predominantly ladies, they may have other coexisting problems like vitamin D deficiency, diabetes, depression, heart problems, other electrolyte disorder and things. And particularly a lot of the medication they take for these concurrent problems exacerbate the symptoms, and probably some of these could explain the symptoms, but not in everyone. I do have some of my patients who is relatively young, having no other comorbid features, and on proper dose of thyroxine, still have ongoing symptoms. So if there's something else going on, despite adequate T4 replacement, why are they unhappy? So do they have tissue hypothyroidism, and can we do it differently? So there are a lot of explanation for this. There have been a lot of theories. So what they're suggesting is, in some of these people who are unhappy with the thyroxine replacement, they may have had low normal set point for TSH prior to this hypothyroid problem, either autoimmune or post-operative thing. And they're used to have a higher circulating levels of thyroxine. So in these people, we probably may not be adequately replacing the thyroxine therapy. We may try to keep the TSH in the middle of the reference range, but in fact, they may probably need a slightly lower end of the reference range sort of thing. And also, in a normal patient who hasn't got a thyroid problem, you do see this diurnal TSH secretion. So, if the patient has measured the TSH in the sort of a midday or slightly after midday, where the TSH may be at the lowest, it can falsely tell us that the TSH is normal. So, and we try and not adequately replace them. And there have been a lot of smaller studies and theories suggesting that T4 replacement is just not the end of the story. Just normalizing the TSH doesn't mean that the patient is right. A normal TSH only tells us how this patient TSH compare with the other individual who hasn't got a thyroid problem. But remember, we are not treating the numbers, we are treating the patient. Of course, the management of tissue hypothyroidism, the best available evidence is LT4 replacement therapy. What is the optimal dose is replacement. If I ask 10 endocrinologists, we will each have different answers. But vast majority of us may agree that we try to keep the TSH in the mid-normal reference range, or some of us might say low normal reference range. So one of the solution is, if someone unhappy with the TSH in the middle or slightly in the upper end of the reference range, try and increase the dose to try and keep the TSH in the low normal reference range. See if that make any difference. And also, please always look for other coexisting problem. In Manchester, Salford Royal Hospital, I used to do a clinic called chronic fatigue syndrome clinic, right? Vast majority of us probably don't agree that an entity exists until I start doing them. And you have to see people who brought into a clinic in a stretcher, young girls who hasn't got any other problems, ending up clinic in a stretcher. And earlier I was quite dismissive and I wasn't very agreeable to this chronic myalgia symptom, but we have more and more evidence saying, yes, there might be an entity. So a lot of the proper medical illness, which was dismissed in the past as a fake or feigning, now we do have a scientific explanation. So please try and look for other coexisting problems. And importantly, always consider T3 replacement if this patient are unhappy. Well, I'm going to open a Pandora's box when I talk about T3. I do know that. But there is a very small subset of patients who I treated with a combination of T4 and T3 did subjectively well. I do agree that there is not many randomized controlled trials to support this one, but there is a small role, and my suggestion would be to try and use T3 in very few subselective patients who are still unhappy. So to summarize, I believe that tissue hypothyroidism exists. Physicians are often dismissive of the symptoms. We try and treat the numbers rather than the patient. Please listen to the patient, try and treat the other coexisting mortalities and morbidities, and please always consider T3 at the end. Thank you.
Thank you, Dr. Shankar. That was very, very precise and neat. I would, due to time, I'd welcome Dr. Sriram Magadevan. Good evening, sir. Welcome to the forum. And we would expect kind of your way of the judgment on the topic, please.
Good evening, everybody, and profuse thanks to the organizing team, Dr. Krishna sir and others, and Abbott also for giving this opportunity. I would am I audible and my slides are visible?
Yes, sir.
Okay. And so being a debate, I first of all thank my opponent, Dr. Shankar Dandapani, for giving an outline of the condition and there are a couple of issues which already is in favor of what I was trying to say. Even though he tried to bring in the concept of tissue hypothyroidism, 2-3 things were grossly, I would call a mismatch for the clinical presentation. The case which he presented as a prototype was a young lady who, and that too had undergone an organ removal, thyroid. I don't know whether she was hypoparathyroid. And I distinctly remember one of my patients some time back asking, he has also undergone a thyroidectomy sometime in the past, and he has read the net and said, "Sir, you are replacing only thyroxine. Why are you not replacing calcitonin?" It's also removed along with that. So yeah, our patients are much more intelligent than us sometimes. And in the end, Dr. Shankar Dandapani, as expected from a good clinician, already let the jury out, I suppose, saying that you should look for other causes rather than harping on thyroid and adjustment of thyroid. Even though he briefly mentioned T3, but he stressed that as physicians, we have to look at the patient holistically. So with this in mind, in the background, I would go through the audience who are seeing this, or even my colleagues. This is not an ECG strip. That is the clue. You'll be surprised to learn from the next couple of minutes. I'm going to say, what is this? This is one of the a graph which was used in the past. I will tell you more about this as we go along. And it's directly related to hypothyroidism. And we all know hypothyroidism, or whatever, thyroxine physiology. Thyroid hormone belongs to the nuclear receptor superfamily, and it has a nuclear receptor. Obviously, it's going into the cell, and it acting on almost every nucleated cell in the body is directly dependent on thyroxine for its optimal function and maintaining the homeostasis. And there is no doubt that thyroid acts at the tissue level. This this whole topic, as I was repeatedly pondering and brooding in my mind as to what is this and why they are discussing this, I was repeatedly coming under the impression, personally at least, that this word itself is probably a misnomer, because there is already we are diagnosing hypothyroidism based on a tissue diagnosis. When I say tissue, it is not FNAC or those kind of tissue. Ultimately, pituitary is a tissue. From there, tissue TSH is coming. You are taking a marker from there, and that's how I look at this whole thing. So, as has been already, the stage has been set by Dr. Shankar Dandapani. Hypothyroidism in a patient, especially primary. I will also mention that in pituitary, we don't use the same formula. We have T4 as the formula, and there we go by other things. So, in primary hypothyroidism, some of the patients, as he mentioned, maybe 1/4 in some series. And there are, I think, one of our Tamil Nadu colleagues, who was in the UK, Dr. Ponnusamy Saravanan, has done quite a few studies on this, on how many patients are unhappy. That word unhappy could be due to multiple reasons, and it's extremely difficult to believe that it's due to the thyroid. So persisting thyroid symptoms, even after normalization of TSH, is the background of tissue hypothyroidism. So in severe hypothyroidism, it's most of the patients will, especially in our typical Indian setting, will in fact see you like God once you start thyroxine, and they dramatically recover. So there is no problem, and you are seeing only tissue changes, including some weight loss. Dramatically the voice will change, everything will happen. There is no problem. It's all, after all, tissue effects. And how many patients who are having those persistent symptoms, invariably, if I'm not mistaken, I think my colleagues will agree, it is most likely in subclinical hypothyroidism patients who will otherwise also have non-specific symptom. They will not have this TSH correlation already, and we are already starting on a doubtful biochemical parameter. So that's where the starts. Then they have varying symptoms, and you will get a varying outcome in spite of normalizing TSH. And why I put secondary hypothyroidism is just to tell you that this whole discussion is probably out of context. But in secondary, in pituitary, we don't consider this tissue level discussion. There are already other hormones also which are deficient. So I will leave it for the discussion purpose. So answering or trying to answer this question, why there should be persisting hypothyroid symptom in a patient who is on reasonably optimal doses of thyroxine and normalized TSH according to current guidelines. As has been already pointed out, whether it's due to thyroid, we don't believe usually, and that is what we practice as of today. TSH is used as a very sensitive biochemical parameter, which is a surrogate marker of normalization of tissue level euthyroidism or hypothyroidism at the pituitary level, and pituitary is taken as a surrogate for the entire body. This is how I look at it overall. And when the pituitary normalizes, and when you use a very sensitive parameter like TSH, we need to wait for some more time for other tissues to also become euthyroid. But it's not that every symptom will be related to thyroid, even if you go by our general medical principles. So tissue hypothyroidism is probably not the correct term to use. We are already using a tissue-based diagnosis. These kind of papers are n number of papers available. Just a recent one in some journal where how many patients had these kind of symptoms persisting even after treatment. This is again from I think this is from US. And again, they are saying that in this paper, as nicely, it's a pharma-based pharmacology kind of paper. Patients who are experiencing symptoms look for other causes. That's what they are mentioning. And we all accept, we are not dismissing those symptoms. We are only looking for alternative explanation other than thyroid is the first impression. This was one of our small attempt to see, this is not for tissue hypothyroidism, but I was thinking about our study, which we did a couple of years back, where how much time does it take for TSH to normalize, which I am mentioning now as an important surrogate marker for thyroxine to normalize the pituitary. There you see it is less than 14 days. Usually we go by half-life of thyroxine, which is usually 7 to 10 days. So usually we call patients in clinical practice only around 4 to 6 weeks, if at all you want to quickly normalize. But this paper was slightly an eye-opener for us to show that many of our patients unnecessarily go to severe hypothyroid state after thyroidectomy. And to our surprise, almost all patients, if the surgeon had done a good thyroidectomy, your TSH will go very high, more than 30 to 40 within 2 weeks. And this we are now using it in our patients who are going for surgery in the next few days. You need not wait for 4 weeks, sometimes you can. So this shows that the pituitary tissue and its secretion to normalize will not take more than 2 weeks. This is not to say that all other tissues will happen in the same way. You have to go by some more, even if you go by half-life of thyroxine biochemical levels, minimum 6 weeks, and wait for other symptoms to go. So I am repeating. So what I understand, if others also agree to this, is TSH is a very good marker at a tissue level for pituitary. And tissue hypothyroidism is most likely a misnomer. And all organs will not respond in the same way like TSH. So we have to wait for some more time. If after a reasonable euthyroid state, which I mean by TSH in the lower half of normal, if that is acceptable, for more than 2-3 months in a given patient, and if they are very, very compliant, I'm sure compliance is a very big issue in our setup, you need to look for other causes. And you may call it tissue-specific thyroid sensitivity or resistance. This is, I will not spoil your Sunday evening by showing complex diagrams. The listeners, just to tell you, these are all based on animal studies. One of these, this concept of tissue-specific thyroid sensitivity or resistance is coming up or explained at a biochemical or at a cellular level by the difference in the deiodinase enzymes at various tissues. As you know, in the pituitary, it is deiodinase type 2, and it is type 1 in the other places. Polymorphisms of these enzymes are well known. So each tissue will actually respond differently to the same level of thyroxine in the blood. And it is auto-regulated within the tissue, what is called intracrinology, if I can use that term. Similarly, they have also found out that even though I mentioned the TSH, thyroid hormone as a nuclear receptor, we know that it has alpha and beta receptors, but that is the typical canonical receptor-based effect. There are non-canonical pathways documented in animals, which include on the integrin pathway, the other, there are DNA independent effects, non-genomic effects of thyroxine. All these will take different time period. And we might have to counsel our patients that you have to wait for some more time in many of our patients.
Dr. Sriram, 1 minute.
Yeah, maximum 2 minutes. Sorry, thanks. So this is just to tell you how TSH is such a sensitive parameter. I'm not going into the pregnancy discussion. This was one of our colleagues, Dr. Ponduswamy Saravanan, as I already mentioned, and others from UK. You see, even within normal TSH, you have so many tissue-specific variations in the response, as been documented in Lancet long time back as an editor, as a commentary. And I am reminded of Butterworth and Papworth publications on clinical medicine before the era of thyroxine TSH assay. Use photographs is what they have told. So are we going back to that era that you are basing on tissues? And as I mentioned, this graph which I mentioned is photo-moto graph, which one of our senior professors, he's no more now, Professor Kannan from Madurai has also mentioned, done this in Madurai. This is like ankle jerk which is documented to be very delayed and hung up the Hoffman sign. And I'm not sure if this is what is tissue hypothyroidism. This will happen only in severe hypothyroidism. You will never have it in other conditions. So I don't think we are going for a U-turn in our entire approach to hypothyroidism, where in the pre-immunoassay era we were using all this tissue-based diagnosis. Today we have gone to the biochemical, very sensitive biochemical parameters, and again you want to go back to tissue level. I think that is to be questioned as much as possible. So of course we have to use our clinical sense. So many tissues are available. Which tissue will you use? Going by the patient symptom, if they complain of muscle ache, I will use creatinine or creatine kinase. I don't think there is any consensus in all this, and these are all not sensitive at all. We know that in practice. So as has been mentioned by my opponent, even if diagnosed as tissue hypothyroid, propose, I also agree with him. How do you treat? Would you go by symptom? Or as I mentioned, go for alternative therapies? Would you modify the LT4 dose? Keep the TSH lower? How low? If you go was more low, you'll have cardiac and osteoporosis issues. So it's a very, very tricky thing. And enough of papers have been published on T3 with T4 and T3 alone. They are all more and more, questioned, and their effect on, they have more side effects than effects. And these are latest consensus in European Thyroid Journal, which again says that there is no role for T3 or T3-T4 combination in clinical practice. So what is it leading to? These kind of pseudo medical people. One Dr. Wilson has published all this tissue hypothyroid concepts, tissue temperature syndrome, hypothyroid like Wilson syndrome, and our guidelines, the American Thyroid Association, Mayo Clinic, everybody is going at giving counter statements for this. So all these tissue hypothyroidism concepts have led to pseudo practice and already quackery in India. And I think we should put a full stop to this whole tissue hypothyroid. So my thoughts are, this is most likely a theoretical concept, even though there could be some hypothetical basis for this. I also agree to that. But if you see the patient holistically and use TSH appropriately and judiciously with your clinical acumen, you will be able to evaluate and counsel your patients well. And I wouldn't agree with this tissue hypothyroidism concept, and I wouldn't be treating based on the thyroid being a reason for some of the symptoms in a given patient. Thank you very much for your time.
Thank you, Dr. Sriram. But for our traditional debates, I've been asked to speak on this for 10-15 minutes as well. So I've got a few slides to go through this evening. So let me share my screen first. I think we had a wonderful session from both the speakers. And can you see my slides, Dr. Sriram? Yeah, fantastic. Yeah. So I'm just going to give you a broad overview of the whole thing because they've been short of time as well. So my thought process in this topic, has it already been introduced by both the speakers, is dissatisfaction has been a major outcome of thyroxine monotherapy in our clinical practice. So at least 10 to 20% of our patients complain on this. And persistent symptoms like fatigue, weight gain, probable memory issues, thinking, and mood disturbances are very, very common in our patients. So these are, we find it very, very difficult to address these in a clinic setting. And generally speaking, T4 monotherapy is associated with low serum free T3 levels, which are often, we are unable to explain this to our patients, but we know that at lower levels, the sensitivity of our free T3 assays and total T3 assays are not that good. But newer studies in the last few years have enlightened us about possibilities of peripheral tissue thyroid function and where we should maintain these thyroid levels for our patients. And there has also been instances where our thyroid hormone TSH acts differently, especially in the hypothalamic region, whereas our other peripheral tissues are differently sensitive to one another. So whatever we are seeing, a normal TSH like 2.5 or 3 might not be the same as a euthyroid state. Let's have a look at the evidence for that. So up to 10% of our patients still with the low TSH, normal TSH, have these problems, and I've explained to you. And there has been multiple surveys in this regard. And the latest out of that was 2019 online survey of hypothyroid patients by the American Thyroid Association. Demonstrates significant patient dissatisfaction just on thyroxine therapy. And this was preceded by a population-based survey prospectively from the UK, Netherlands, as well as Norway, which almost most of them were dissatisfied, and a patient satisfaction scale, levothyroxine scored the least at 5, whereas a desiccated thyroid extract scored 7, which was the highest. So this is just kind of looking at this data, and also people have been thinking whether we are doing the right thing. And mostly this dissatisfaction has been at energy levels, fatigue, weight management issues, memory, problems with thinking, and mood. So whether these are real symptoms or whether these are preceding symptoms which are present in patients which have been noted after our diagnosis of hypothyroidism. So is there a biological rationale for persistent complaints in levothyroxine-treated hypothyroid patients? And I've based my talk on Professor Veerasinghe's review, the most recent review from 2019. And what he has suggested is non-specific causes related to the chronic nature of the disease can account for it. Possible associated autoimmune diseases also have to be looked into it for these symptoms. As Dr. Dandapani mentioned, thyroid autoimmunity per se can also lead to non-specific symptoms. Inadequacy of the LT4 dose and inadequacy of LT4 treatment as a modality itself could be causing it. The problem, what he was suggesting was a lot of patients being aware of a chronic disease, lifelong dependency on the medication itself could be a possibility of patients being unhappy and less healthy. So this might affect their anxiety and depression scores as well. There is, until today, no prospective long-term studies to assess these attitude perceptions and moods in our hypothyroid patients without any drawbacks. And even in things like our meta-analysis studies, the studies involved are very, very small, and they are dependent on very, very non-specific measures of feeling good, satisfactoriness, and so on. The other major thing has been is lack of physician participation, mostly general practitioners and nurses. The time for interaction with these patients have been noted to be smaller and dependent on number base. As Dr. Dandapani was alluding, we are basing our decisions on TSH-based treatments and not from what we are hearing from the patient. That's been one of the key areas which has been identified by patients themselves. And this leads to future probably poor adherence and suboptimal treatment, worsening their comorbidities as well. So physician interaction remains a key in this. And obviously hypothyroidism is an autoimmune disease, and other autoimmune diseases have to be looked at, like B12 deficiency, Addison's disease, if the symptoms are very predominant. So you need to be alert for that. Effect of autoimmunity itself. This was an interesting study I came across the first time today, where they looked at 130 patients who had total thyroidectomy instead of replacing just their medical therapy, and they felt much, much better, and their antibody levels decreased from around 2000 to 150. And this is slightly interesting thought. There is no proof of concept here or a causal relationship here, but it just gives us an extra bit to think whether we are doing the right thing. So this is whether autoimmunity might be a reason for our patients to feel bad about themselves. And we've had concepts on deciding our T4 doses. And as I earlier told you, that measurable changes in T3 and T4 are not reproducible most of the time. And for us, again, we get the help of surgeons here. Free T3 levels compared to pre-surgery, post-surgery. If you get your TSH to around 0.03, only then you replace your thyroxine to medium levels. This is one isolated study, as I say, but you need your really low TSH levels to get appropriate normalization of tissue levels. I've got a slide to show you that. I think it's the next one. So whether our current measures of TSH replacements are inadequate, we don't know that yet, but this is one particular study. And I think both the speakers touched on this, whether the deiodinase mechanism in the hypothalamus is different from our peripheral tissues. That's a kind of an argument where anybody puts on, where you have a stable deiodinization mechanism, which is prolonged in the hypothalamus, whereas we have got a very, very short half-life in the peripheries, which leads to faster deiodinization and degradation of the thyroid hormones, which leads to more dosage to have an impact. This is exactly what I meant. Here, in a nutshell, they compared certain markers of thyroid status like the LDL-C, sex hormone binding globulin, the TRACP, and the bone alkaline phosphatase to pre and post surgery. And they titrated the dosages, and only when they're reaching levels around 0.03, they were able to match the tissue levels. And this was postulated as to reduce our replacement levels further down for patients to feel better. This is just one concept. So what do we have to tell our patients and do things? So we've got levothyroxine, we've got T3, we've got a synthetic mixture, we've got desiccated thyroid extracts as well. But I have to warn you, still the ATA recommends only levothyroxine for treatment, standard treatment of hypothyroidism. And world over, levothyroxine is the standard of care. Our priorities here is to provide resolution of patient symptoms in most of our patients, to reduce biological and physiological markers of hypothyroidism, to achieve normalization of TSH and improvement in the hormone concentrations, to avoid iatrogenic thyrotoxicosis as well. So these are the three common priorities of thyroid hormone replacement therapy. And we have different quartiles for pregnancy, and I'm sure you're all aware of it. But the advantage remains with thyroxine is the long half-life, availability of multiple tablet strengths, ease of absorption, and absence of clearly documented benefits. We use T4 with the absence of clearly documented benefits of additional T3 replacement. So importance, where do we stand now? So until or unless we look at special circumstances like central hypothyroidism, our TSH offers the best chance to assess thyroid function. Sometimes we monitor 6 monthly or a yearly, although that's not very much evidence-based, but 6 monthly or yearly is fine. But when your patient is getting older, they might need decrease of their thyroxine dosage. That's what is very, very important. So you need to be alert and ready to reduce their dosage up to 10 to 20% as they get older and cross the 6th or the 7th decade. What do you do if there is persistently elevated TSH in patients who are said to be taking their thyroxine? And the most frequent reason for persistent elevation is still compliance issues and nothing else. Sometimes patients just take their thyroxine the week before they turn up to the doctor and just basically inform the doctor they've been taking it regularly, which could also be a common cause of a normalization of free hormones or total hormones of thyroxine and still an elevated TSH. Tissue level unresponsiveness to thyroid hormone is very, very rare, unless it's a rare condition which endocrinologists are very familiar about, thyroid hormone resistance, which is a very, very uncommon condition. And tissues, the pituitary, the heart, and the peripheral tissues develop different forms of thyroxine to each other. So there are some conditions. I'm not going to go into all of these. I'll just rush through. In cases of malabsorption, atrophic gastritis, or any antacid interaction, you need to increase the dosage. There are some instances with particular doses you need to increase. There are some where patients lose their weight or taking androgens, they might need a decreased dosage. So these are interactions where you need. We've been traditionally following a combination of T3, T4 in patients who have been unhappy. You've probably seen this study, this table for a long, long time, many, many years, where these are particularly very, very small number of patients in these particular studies. Half of them felt somewhat better in their cognitive assessments, but nothing else. So this is kind of initial studies which have used this. But the reason for the most unhappiness in our meta-analysis is these are very, very heterogeneous group of studies, and the summary is they have not been assessed correctly. What does the ETA say, European Thyroid Association? When patients are unhappy, I'll skip the slide. When patients are unhappy, they should be given a trial of a free T3 and a T4 dose. And I've just portrayed you a table where what are all available. We will mostly concentrate on the T3 and T4 prescription, but there are, I'm sure, most of our physicians are also available, aware of the desiccated thyroid extracts, which is available all over the world. And what do you do when you want to convert them? And the table on the first column shows that if you want to convert somebody of 100 micrograms of levothyroxine, you give 5 to 10 micrograms of T3 and the rest as a T4 dose. So this is kind of, which is widely available, but unfortunately the cost of T3 has gone up significantly in the last few years. Thyroid supplements, a big no-no for patients with the thyroxine supplementation. And none of the medical organizations recommend this. And primarily coming back to our speakers, both speakers, they've given a full view of, we assess most of our patients, do a full thyroid panel, rule out celiac disease, do a dietary assessment to make sure they are taking adequate micronutrients, check their antibodies. And if at all there is any deficiencies like B12 identified or de-identified, you give them that, give them a healthy diet. And if at all they've got any occupational exposures or endocrine disruptors hanging on the backyard, then you might also have to work on them. So vitamin D, when there is low, replace them. Selenium can also be given for a short period of time, especially in patients with thyroid ophthalmopathy. B12 is known to be a common acquaintance of our patients because of the autoimmune focus. And finally, one last thing, not the least though, a lot of the complaints or our problems of our patients arise from misunderstanding the condition from the patient side or from the doctor's side or both sides. So the patients, it is our duty to make them understand the condition, tell them it's a chronic condition, it's an irreversible autoimmune process, which may help them, and giving them a good prognostic index also will help. We obviously, most of the psychological studies have shown that improvement in patient relations happens through empathy and observing patient behavior. We need to enhance our communication skills through adaptation of our own communication needs and behavioral style of the patient. Better therapeutic, this will help us build better therapeutic relationship with our patients and also improve their adherence to the therapeutic regime. My final slide, significantly more and more patients are receiving hormonal therapy in today's world. Their residual symptoms are important to them, and it is our duty as physicians to enlighten them. Attempts at times should be made to help them, or at least a trial of therapy can be given with a combination of T3 and T4. You should evaluate patients holistically to look for other non-thyroidal clues for persisting symptoms. And last but not the least, a combination therapy can be tried by an adequate medical personnel. Thank you so much for listening. If Krishna permits, we'll take a couple of questions.
Short ones, please. Short ones. There are questions in the chat box, by the way.
Let me take it. One second. Questions from Dr. V. Pranesh. Once hypothyroidism sets in, is it a lifelong levothyroxine is given? Dr. Sriram?
Being an autoimmune process, the process can be going into remission and exacerbation. So in general, if the immunoinflammatory process is severe and the gland undergoes atrophy, which happens in 60 to 70% of patients, the general statement that it is lifelong therapy with thyroxine is true. But there could be a 10 to 20% patient at least where the autoimmunity can go into remission, and you will be surprised to see some of the patients going in for, here. I mean, those are the patients who will be usually subclinical initially. So let us give a positive note to many of our patients. The moment they come with the TSH of 30, 40, don't always say it will be lifelong. This is a practice point. You could recover in 10-20% patients is what you might say. It is biologically also explainable. Except these radioiodine ablated and the thyroidectomized patients. That's okay. That's the gland is not there.
Dr. Shankar, Dr. Sridhar wants to know the role of micronutrients and T3 dosage and frequency in probable tissue hypothyroidism.
Right. The role of micronutrients, I don't generally use micronutrient replacement in hypothyroid patients. The occasional mild Graves' disease patient, I have used selenium, but there is some small evidence to suggest it might be helpful, but not in hypothyroidism. The second one is T3 dose. When I use a combination therapy, I roughly use around a 10:1 sort of thing, like what you said. If someone is on 100 microgram replacement, I might give instead of a 5 to 10 of T3 and the rest as a T4.
Thank you so much. I think we will hand over the mic to Dr. Krishna. Thank you so much, Krishna. We had a wonderful time in doing this program.
Sriram wants to make a last comment on this.
One small, see the sponsors of this project, I think Abbott was having one very catchy name, thyroid thing, Thyro-Well, that was a supplement which included selenium and L-tyrosine and everything. And many patients, instead of taking Thyronorm, they were taking Thyro-Well for some time. The supplements are sometimes a problem in our setup. They will take the vitamins rather than the main tablet.
Thank you, Sriram. I think that is important. The symptoms of thyroid are the symptoms of life is what my boss Chuck Cannon said, and I think sometimes it's very difficult to separate life from the thyroid. Dr. Joshi, are you here?
Yes. Hi, sir. And thanks a lot. Thank you so much, Dr. Muthukumar, and thank you so much, Dr. Shankar and Dr. Sriram, for sharing your views. So quickly moving on to the next session, that is a symposia, which would deal with topics like TSH in pregnancy, TSH and infertility. And to moderate that, we have Dr. S. Murthy with us. Sir is the director in the Endocrine Diagnostic and Research Center, Diabetic Care Center in Chennai. He has been formerly the Associate Professor of Endocrinology in the Madras Medical College and Government General Hospital, Chennai. So over to you, Dr. Murthy, sir.
Am I audible?
Yes, sir, audible.
Yeah. Good evening, friends, and thank you very much, Dr. Krishna and Abbott, for this privilege and honor of chairing this session. This session will have 3 talks. The first one will be by Dr. Karthik Balachandran, and he will be talking on TSH and infertility. Dr. Karthik Balachandran is a consultant endocrinologist and assistant professor at Sri Ramachandra Medical College and Research Institute, Chennai. And he is going to be talking on TSH and infertility. Over to you, Dr. Karthik.
Thank you very much, sir. Good evening, everyone. First of all, I would like to thank Krishna Sheshadri sir and Abbott team for this opportunity. A brief technical check before I start. Is the screen visible? Am I audible?
Yes, sir, all good. Please continue.
Yeah, thank you. So, good evening, everyone. My talk today would be on TSH and fertility. So we have 2 issues here. One is fertility or rather the thing that we care more about, the lack of fertility, which is infertility, and how TSH is associated with it and what we can do about it will be the focus of today's talk. So infertility is defined as an inability to conceive after 1 year of regular unprotected sexual intercourse. It is fairly common, seen in about 10 to 15% of couples. And when we look at who is the problematic person in the infertility, we can see that it could be male, female, both, or idiopathic. It's all fairly evenly distributed. Now, the next question is about TSH and infertility. So we can see here, when you think about thyroid, it is very important to remember the basics of thyroid physiology. And the most basic thing is this kind of inverse log linear relationship between TSH and T4. Now you can think of it as a seesaw where T4 is sitting at one end and TSH is sitting at the other end. T4 can be thought of as a bulky kit. Small changes in T4 result in massive changes in TSH. So even tiny rises in TSH could signal a deficiency of T4. Now, looping back to the original question, is TSH related to fertility? And if so, how much and what we can do about it? Like any other thing to study the relationship between two entities, we need to show that there is prima facie some biological mechanism to link these two entities. And next is to show if there is any evidence for that biological relationship which is seen in the lab. Thyroid hormones and female infertility, there are lots of links. It can affect by direct mechanisms involving the ovary or the hypothalamo-pituitary ovarian axis. FSH and T3 act together on the granulosa cells. Thyroid hormone regulates the aromatase activity sitting in follicular development. T3 and TSH receptors are present on mature and developing oocytes. There are also indirect mechanisms like alteration of clearance of hormones, decreased sex hormone binding globulin, increased peripheral aromatase activity, and increased prolactin levels. So the link between thyroid hormone and female fertility has several strands of complexity that run underneath, and there are frankly more questions than answers as of this latest review by Pop et al. Now, okay, there are some biological mechanisms. Do we have strong epidemiological evidence, at least to suggest if these two things are linked? The first question to ask is, do infertile couples have higher prevalence of either hypothyroidism, where TSH is high, or hyperthyroidism? Now, this is a study by Oroji et al., which looked at TSH levels in unexplained infertility, and they found that TSH was associated with fertility even within the normal range. So even when the TSH is within the normal range, those at higher level of TSH within the normal range had lower fertility compared to those with lower levels of TSH. This is an Indian study by Indu Verma et al. They found that out of the women who presented to the clinic, about 1/4 were hypothyroid. And most importantly, nearly 75% or more of these infertile women conceived within 6 weeks to 1 year of treatment of that hypothyroidism. So it was not just an incidental finding or some laboma that came out because of TSH cutoffs, but it was a real biological problem in nearly 1/4 of the women. So we can say that hypothyroidism in one way or the other is associated with female infertility, and even having higher levels of TSH within the normal range can impair fertility. Now, what about male fertility? Can thyroid hormone be associated? Yes, several mechanisms are there, just like for the women. Increased prolactin, hypogonadotropic hypogonadism, low libido, low sperm motility, all of them result from increased TSH hormone. This is a study by my junior in JIPMER. We basically studied 40 patients before and after treatment of hypothyroidism. It is important to realize that 80% of the patients had some degree of sexual dysfunction, as shown by Adam and ASEX questionnaire, and all of those questionnaire items disappeared after treatment with thyroxine. but these were all overt hypothyroidism patients. And after treating the hypothyroidism, we can see that total motile sperm went from 30% to 80%. So there was a massive jump in sperm quality, life quality, as well as hormones in treatment of hypothyroidism. So hypothyroidism can be associated with both male fertility and female fertility, and treatment improves both male fertility and female fertility. Now we have seen the high end of the TSH spectrum, but what about the low end of the TSH spectrum? Thankfully, the low end of TSH spectrum is relatively rare compared to high end, and suppressed TSH is not more common in infertile people compared to normal population. So we can say that the impact of low TSH on fertility is considerably less compared to the impact of hypothyroidism on fertility. Now, coming back to the ways in which thyroid hormone or thyroid gland can be associated with fertility, we have been solely focusing on hormones, that is, decreased thyroid hormone and resultant increase in TSH. But there are two other components to consider. One is autoimmunity, other is the micronutrient or the lack of micronutrient thereof. Now, autoimmunity is associated with increased risk of both difficulty in conception and increased miscarriage rates, as shown in this graph by Poppe et al. And autoimmunity can be tested by anti-TPO antibody, anti-TG antibody, or both. Interesting thing in the study by Unuan is that if we test both, we will pick up roughly twice as many cases as just testing anti-TPO. So there may be a point in testing more antibodies, but it doesn't really matter whether we choose anti-TPO or anti-TG. Now, unlike thyroxine replacement, autoimmunity is unfortunately not easily treatable, and there is no role for any steroids or any other drug in reducing thyroid autoimmunity for the sake of improving fertility. Now, the third thing that we need to consider is the micronutrients, of which iodine is the most well-known one. It is taken up avidly by the ovary and endometrium also. Apart from thyroid, this is not so commonly known. Iodine deficiency is associated with fertility even if TSH is normal, and use of high iodine contrast media incidentally in patients who are infertile was found to be associated with improved fertility in unexplained infertility people. So iodine is associated with infertility not through thyroid but directly as well. The other micronutrient is selenium. Selenium is associated with thyroid in a roundabout way. Its deficiency is associated with adverse pregnancy outcome. And supplementation at 83 micrograms per day was found to reduce anti-TPO levels, improved outcomes by this study in Dantas. It's a small study. Unfortunately, there are no reliable markers for selenium, and the thing also has low therapeutic index. Therefore, it is not recommended by American Thyroid Association, or for that matter, any other thyroid body level. But not being able to give selenium or iodine as tablets doesn't mean it can't be improved in the diet. There are plenty of dietary sources of selenium, and they can be taken to improve the situation in patients, and these are not controversial. And selenium deficiency usually develops in patients who are otherwise also in nutritionally precarious state. So there may be a point in improving their nutrition per se. So we have established that thyroid problems are associated with fertility, and treatment of thyroid problems improves fertility. The next question is when to treat. So again, before embarking on treatment, we need to show that thyroid problem causes infertility. Treatment of thyroid problem improves not just conception, but also live birth rates. Because if a treatment improves conception, but does not affect the miscarriage rate, that would not be of much use to us. And finally, the most important thing is that the treatment must have favorable risk-benefit ratio after careful consideration of alternatives and the natural course of treatment. So looping back to the trifecta that we have here, hormone, we can do something about it. Autoimmunity, nothing much can be done. Micronutrient, we can't give any tablets or easily improve the situation. So the only leftover thing for us to do is to give thyroid hormone. Now, whether to give hormone or not itself depends on the level of TSH, and TSH can range in a spectrum from clearly normal, that is less than 2.5, to clearly abnormal, that is more than 10. The in-between range of 2.5 to 4 or 4 to 10 is where the problem arises. 2.5 to 4 will be the focus of my talk. PSH of 4 to 10 will be covered next by next speaker. Thankfully, the guidelines come to our rescue, and the guidelines state that if the TSH is less than 2.5 and antibodies are positive, we may still consider giving low dose thyroxine in some patients. This is a highly controversial thing because if the TSH is normal, and what are we really treating with thyroxine? But for people with infertility, poor obstetric history, this may be considered. Antibody negative, there's no need to give treatment. 2.5 to 4, again, if it is antibody positive, we can consider, and for antibody negative, it's not recommended to treat. 4 to 10, antibody positive, definitely go ahead and treat. And if it is antibody negative, we can consider. And above 10, everybody needs to get treated. So if we have to summarize this table in one sentence, I can say that the guidelines tend to favor or err on the side of treatment in antibody positive women, even though what we are treating is not the antibody level or autoimmunity itself, with the hope that the pregnancy outcomes can be improved. The reason for this is that thyroxine is a naturally occurring hormone, and at very low doses, it's unlikely to cause significant harm. Because of the solid cost-benefit ratio, this drug can be given to improve the fertility outcomes, even if the TSH is fairly 2.5 to 4. So we have talked about the fertility and thyroid and how to treat, when to treat. It would be incomplete without talking about artificial reproduction techniques. The number of oocytes retrieved is not influenced by thyroid function or thyroid autoimmunity. And this is the 2021 European Thyroid Association guidelines prior to ART, and LT4 does not improve oocyte retrieval rate. So women with hypothyroidism should just have a normal TSH less than 2.5 before undergoing ART. But if they already have normal thing, then we may not really treat them. Screening, this is from the ATA 2017 guidelines. Symptomatic women above 35, family history of thyroid illness, irregular menstruation, recurrent pregnancy loss, and those with infertility. In general, any woman who's not getting pregnant or not delivering because of something that goes wrong in the pregnancy would be an ideal candidate to screen for pregnancy. So to summarize this talk, thyroid dysfunction definitely affects fertility, especially hypothyroidism, compared to mild reduction in TSH. And patients with infertility should be screened for thyroid dysfunction with at least a thyroid function test. And if that thyroid function test shows a TSH value of above 2.5 but less than 4, there may be a point in testing antibodies. If the antibody test comes positive, then as the guidelines suggest, we may favor treatment in such a patient, given that thyroxine is safe in safe hands. And if the TSH is above 4 in an infertile woman, it's a straightforward thing to treat. So the whole thing is that thyroid dysfunction affects fertility. It can be improved by simply giving thyroxine. There is no role for any drug to improve autoimmunity or even micronutrients in the setting of infertility. So thank you so much for listening. That brings me to the end of the talk. Thank you.
Thank you very much, Dr. Karthik, for that very elegant and lucid presentation. We will have the discussion after the end of the next two talks. And the next talk is by Dr. Sridhar, Dr. S. Sridhar, and he will be talking on TSH more than 4 and less than 10, controversies and care in non-pregnant. Could I have the biodata? Yeah. Dr. Sridhar is an associate professor, Department of Endocrinology, Madurai Medical College, Madurai.
Yeah, thank you, sir, for your kind introduction. And so, good evening, one and all. At the outset, I would like to thank Dr. Krishna Shah as well as the ABBA team for giving this opportunity to speak on TSH more than 4 and less than 10, controversy and care in non-pregnant individuals. So everyone will be using the last two instruments that is the most commonly used in our day-to-day clinical practice, that is Roche and Siemens. And every instruments, they have the lower limit and upper limit, otherwise known as a referral range. And many of the times the subclinical hypothyroidism is most commonly being detected in during routine mastocytic checkup. And always in a default, whenever the even mild increase in the point level, it will be shown as a bold and high. So everyone will be maybe getting panic. So that is the way many of the subclinical hypothyroidism is picked up by the routine checkup as well as the non-specific symptoms. And so depend upon the referral range or the instruments and equipments, we can get the TSH referral range. So one should be knows about which method it was done. And there is a good correlations good correlation is there between the free T4 as well as the TSH levels. There is a log linear relationship. And whenever the TSH is going more than 10, there is reciprocally the free T4 is going come down. That is the log linear relationship, and it is maintained, or another hormones, they have this much amount of the log linear relationship. And coming to the statistical point of view, almost 2 standard deviations are less than 5th percentile or more than 95th percentile, they may be outlier. It means that still they may be euthyroid, but the TSH levels may be higher than the normal range. So whether to treat or to observe, we have to make some decisions, and hope the future slides will give some important clue to treat or not. So basically it is a biochemical condition characterized by elevated TSH levels, free T4 or total T4 concentrations within the population specific referral range. And many of the labs, they don't do, or they don't mention about the specific population specific referral range like newborn or pregnancy or elderly. So we have to background knowledge about what is the population specific, or what is the age group specific referral range for these particular TSH concentrations, and they may or may not have the symptoms. So this is the classical definitions of subclinical hypothyroidisms. And why is there controversies regarding to treat or observe? And the basic thing is the normal range of TSH is more dynamic than the previously thought. So the inter-individual or intra-individual, the inter-individual variability and it is more higher with the TSH. Moreover, the timing of the sample, like example, the empty stomach is preferable. And if this patient is on any food item is taken, even still before 2 p.m. is preferable. And the TSH concentrations are lowest in the afternoon and increase by more than 100%. And one more paper also is there by Dr. Sriram Mahadevan. So there is the dynamic variation is there. Whenever the mild elevations in the TSH, it may be picked up or it may be missed, depend upon which time we are doing the sampling techniques. And still almost a lot of evaluation has been happened, but still there is a debate whether to treat or not. It is a long lasting one. And one of the most controversial issues in endocrine practice, unless you observe the clinical knowledge. So the clinical knowledge or the history taking is more important, whether to treat or not should not go by the lab value alone regarding the subclinical hypothyroidisms. And one more entity is that the transient subclinical hypothyroidisms. So basically, it is seen in recovery phase of the non-thyroid illness. And very sick conditions, there may be a suppression of TSH. Whenever there is a recovery, there may be some mild elevations in the TSH. And by some point of time, it will be settled. So there is a transient, the nature of the thyroid illness. And similarly, the recovery from subacute thyroiditis. More commonly, or some group of populations, they will go into the hypothyroidism, depend upon the antibody positive or negative. And some of the populations, they will remain euthyroid. So there may be a transient increase in TSH level, and it will be normalized in some group of populations. And moreover, in drug-induced thyroid dysfunctions depend upon the usage of drugs and dosage. There may be varies, and there is assay interferences like the heterophil antibodies like macrothyroidrophin or biotin used in recently. They have mild elevations, and adrenal insufficiency also, even though they may be a euthyroidal, because of the interference between the cortisol and the TSH, there may be some amount of elevations in TSH. Without thyroxine, cortisol supplementations alone will make the TSH become euthyroidal. So in all cases of adrenal insufficiency, mild elevations of TSH may not require treatment. That is the transient subclinical hypothyroidisms. And whether to treat or not to treat, I have highlighted some of the points. One of the important point is age. So age is very important factors, whether to observe or treat. And iodine status, even though Tamil Nadu is a huge heterogeneous populations, we don't have the iodine sufficiency or deficiency data currently. And moreover, it is not being done in a commercial lab. So we need 24-hour urinary iodine estimations for the iodine status. And I already highlighted about the timing of the sample, and pregnancy, infertility will be discussed by the next speaker. And regarding the etiology, and as already highlighted, non-thyroid illness and degree of thyrotrophin elevations, even though the lab cutoff is around 4 or 4.5. And many of the times we can, for asymptomatic individual, we can take it up to 7, it is a normal. So I will be highlighting in futures. And some of the interactions is there between the obesity and the body weight, and diabetes, and coexisting cardiovascular disease and dyslipidemia, and at-risk population. So these are the one category we have to periodically screen, or we have to, we may attempt to treat, or we have to do the thyroid function test frequently, because of they may be more chance of going into the thyroidisms very rapidly. So any family history of autoimmunity or any other coexisting autoimmune disease like SLE, rheumatoid arthritis, or type 1 diabetes, there is a chance of progression or chance of development of the subclinical hypothyroidisms. In presence of anti-TPO antibody positivity, and any past history of hyperthyroidism. So in the first, you may be around maybe 5% of the hyperthyroidisms, they may be going into the hypothyroidisms because of the nature of stimulating to blocking antibody, or maybe effects of anti-thyroid drugs. And any past history of head and neck radiations, they may be going into the subclinical to overt hypothyroidisms. Any pituitary surgeries or any head injuries in the past, Downs and Turner syndromes, and drug therapy. Coming to the age, so the serum TSH concentrations rises with the age, and it increases particularly pronounced after the age of 70 years. And similarly, newborn, the TSH is up to 10 is normal. And this is one of the congenital hypothyroidism guidelines. And anything more than 20, we have to take it significantly. 10 to 20, it is a borderline or subclinical for the newborn. And less than 20, we can take it normal issues. And based on the TSH surge physiologically, and depend upon the preterm or depend upon the gestational age, we can expect the TSH levels in a newborn. So we have to keep it in mind when interpreting the many of the physicians may be well aware about all these problems. And coming to the subclinical hypothyroidisms in elderly, so age group of less than 70 with the TSH of more than 10, definitely we have to treat. And less than 10, this is from the European Thyroid Association's guidelines. And if symptoms is there, you treat. If no symptoms is there, you observe, or you periodically follow up. And age more than 70, irrespective of symptoms or not symptoms, you wait. And more than 10, again, you treat. So this is the 10 is the magic number for elderly populations, that is more than 70. And more than 80 or 85, TSH is still maybe is a normal findings. And we need more studies in these oldest old subjects. And so we have to use the age-specific referral range for the TSH whenever whether to treat or not to treat for the decision makings. And similarly, in obesity individuals, there is the crosstalk between the hormones, that is leptin, and the thyrotrophin, that is a TSH. And people with the higher BMI or higher obesity, they will have higher TSH. Even though they may be, we can make it them as a normal, but they have, comparing with age and sex matched populations, there will be higher TSH levels, depend upon the body mass evidence. And almost in the consensus statements, there is no evidence for favorable effect of L-thyroxine therapy and body weight in obese individual. And this is one of the paper from European Journal of Endocrinology. You can see that there is the relations between the serum leptin, and whenever there is a more obesity, there is a more and more T4 disposal, and so there is a suppressions of or the tissue free T3. It is low or decreased or equivocal, and it leading to stimulate the TSH. So there is a mechanisms between the crosstalk and thyroid tissue as well as the adipose tissue. And coming to the important other parameters like heart and blood vessels. Thyroid hormones have genomic as well as the non-genomic effect on the heart as well as the blood vessels. And well-proven studies are there, impact of thyroid hormones over the LV diastolic functions at rest and LV systolic dysfunctions during exercise. And the subclinical hypothyroidism also associated with the vascular resistance and arterial stiffness. So some amount of mild elevations in hypertensions also can be documented depend upon the body weight. Moreover, in lipid parameters, if you taken, and the overt hypothyroidism is the one that is consistently associated with elevated total and LDL cholesterols. And subclinical hypothyroidisms, we don't have the clear data, even though it may be a normal or mild elevations, but not up to the mark of the severe elevations in overt hypothyroidisms. So far in the current literature evidence is there is no conclusive evidence for a positive effect of thyroxine therapy on long-term cardiovascular outcome. And definitely it is not there whenever the age group of more than 80. Maybe some studies, they noted the positive outcome between the age group of 60 to 80 age group. So, and we need future large prospective multi-center studies to assess the LT4 therapy on cardiovascular disease and to identify a subgroup of patients who might benefit from replacement treatment. So we need very in-depth studies and depend upon the underlying the cardiovascular comorbidities for the particular therapy and outcome. So we need, we have to, gaps in knowledge are there in this field. And almost all the gynecological symptoms we maybe tend to treat. There is no controversies is there, almost all are consensus, and particularly the menstrual irregularities as well as the recurrent miscarriage. So far, Dr. Karthik already highlighted. And constipations, everyone we may be using with the elevation of TSH, usage of thyroxine. And carpal tunnel syndrome, again, it is one of the important indications from the neurological point of view. And in dermatological point of view, this is the surrogate marker of autoimmunity like dry skin or ichthyosis or vitiligo. So these are the possible symptoms one may tend to use, or one may suspect subclinical hypothyroidism that requires the treatment therapy. And what about the care? And this is the natural, if asymptomatic subclinical hypothyroidism is there, we may wait and see. And we do the repeat measurement in free T4 and TSH after 2 to 3 months. And it should be the quality control maintaining lab, and it should be the same assay and same equipment so that we can able to periodically follow up. And many of the times, more than almost 50% of the subclinical with the TSH of 7, the TSH normalizes within the 2 years. So the in asymptomatic individuals, if TSH of less than 7, we may just wait and watch. If anything more than 7 in asymptomatic, you need close follow-up, or you may be doing the antibody estimations whether to treat or not to treat. And there is a chance of overt hypothyroidism that is happening only in 3 to 20%. And it is more common with the TPO positive individual than the TPO negative individual. And people with goiter, they have more chance of progression to the overt hypothyroidisms, and higher level or rising titers of TSH, they also have more chance of progression into the overt hypothyroidisms. Coming to the management, so treatment of choice is levothyroxines. So the dosage will vary between 12.5 to 75 microgram. So depend upon the TSH elevations, like TSH of very mild, you can start with the 25 microgram. If TSH of between 5 to 7, you may start with the 50 microgram. TSH of more than 7 or 8, you can start with the 75 microgram. So except in elderly populations, as well as in cardiac disease populations, you can start with the full dose. In elderly and cardiac individuals, you can start with the low dose, either with the 12.5 or 25 microgram. And the appropriate LD thyroxine dose and follow, it should be individualized. So there is a no, how often we have to check and how to monitor. There is a individualized care rather than generalized statement. Coming to the last, so the interpreting the TSH of 4 to 10, if it is you assess the lab whether it is standardized lab, and pre-analytical error we have to miss, and the timing of the sample again we have to stress it in to pick up the mild cases. And as already told that the background clinical correlations is very much important whether to treat or not to treat. and coexisting family history and coexisting medications, and whether the past history of any recovery, like a COVID era, maybe some amount of thyroiditis and they may be recovering. So all the history taking is more important. And we should consider the alternative test. So don't go by TSH alone. You either do the T4 or free T4, or in suspected cases of autoimmunity, do definitely anti-TPO. However, it is not going to useful for monitoring. Anti-TPO for only for diagnostic purposes and to identify the etiology. It is not going to useful to monitor and whether the titer is anti-TPO level is reducing or increasing. And common etiology always considers first. Otherwise, you refer to the expert. And so this is less than 4 or less than 4.5. It is a normal. More than 10, almost all cases you treat. And 4 to 7. So 7 you may take as the magic number. And the 4 to 7, and with the symptoms and antibody, goiter, and planning for pregnancy, you treat. And between 7 to 10, and considering the CV morbidities, you can again attempt to treat. So this is one of the paper from the Lancet, and favors observations is obesity related TSH elevation. So this is one of the more common area we may tend to treat because of the parental anxiety. But the guidelines and consensus, there is no recommendations. And absence of antibodies, asymptomatic, and TSH of less than 7, not planning for pregnancy or menstrual symptoms are normal, and no cardiac disease and normal lipid profile, you may wait. And the points favor treatment were positive antibody, TSH of between more 7 to 10, and pregnancy and attempting conceptions or infertility. The symptoms you always tend to treat. And those who want to interest, you can go by this NEJM guidelines, almost a summary. So the last slide is the TSH of more than 10, presence of goiter, and planning or intention for pregnancy, family history and positive antibody, rising titer of TSH. And even though many of the guidelines, they don't mention, so the psychiatric symptoms or any antidepressant medicines, always try to treat them. And the last one is the individualized approach. There is a therapeutic trial, and always you do treat. And the frequent estimation of TFT and sensitive assays leads to the genesis of subclinical hypothyroidisms. So interpretation should be based on the symptoms, pregnancy, coexisting obesity, and the age group, newborn and elderly, should correlate. And management is simple and cost effective. And there is a consensus is there in many of the indications of subclinical hypothyroidisms. So with that, I am concluding my topic. Thank you for your kind attention.
Thank you very much, Dr. Sridhar, for that excellent presentation. And the third and last talk is on TSH in pregnancy, what is normal now and what should we treat. And for this talk, would I have his CV? Yeah, he's a consultant diabetes and endocrine specialist, Ashwin Specialty Hospital, Madurai. Over to you, Dr. Anand Kumar Annamale.
Thank you, sir. Thank you very much. Okay, so as always, I hope you can hear me, and I hope you can see my slides.
Yes, sir, we can.
Yes, we can. Sure, thank you. So at the outset, I'd like to thank Krishna sir, and I'd like to thank the organizers for having me for this wonderful symposium. And my talk is pretty interesting. It's very, I'll try to make it very quick. We're running short of time. So TSH in pregnancy, what is normal now and what should we treat? So my conflicts of interest are none. Like TSH, life is similar. Life is not an exact science, it is an art. So, you know, it is always going to change. So at the moment, TSH in pregnancy, what is normal now? So if you actually look at guidelines, and if you look at ATA 2017, it recommends that when possible, a population-based trimester-specific reference range for serum TSH should be defined through assessment of the local population where a healthcare provider is practicing. Now that is not going to be possible always. So what do you do if you don't have any regional data for a normal TSH for pregnancy? They recommend that you use an upper reference limit of 4 as basically a possible pregnancy-specific range of TSH where you don't have an available data. Now, does this represent a uniform level as to in every country and every region? So the position statement in 2019 of the Indian Thyroid Society and Foxley said that, they recommend that TSH is checked in all pregnant women, and it is recommended that the TSH is actually trimester specific to the earlier ATA guidelines as basically the first trimester TSH of less than 2.5, second and third being TSH less than 3. So there's a little bit of a conundrum as to, what you would follow. Now, I'd like to try to dissect through this and then, make you understand why there is a confusion. So whenever you have 2 or 3 ways to, address this, there's probably not a right way and could be many ways. So this is an interesting publication which came out from China in the JCNM in 2014. And this I chose because this had a huge population representation. This was an Asian population. So 4,800 pregnant women. And what they did was they checked the first trimester TSH cutoff along with the FT4 and T4. So they found that the prevalence of subclinical hypothyroidism amongst this population was as high as 27.8% if you use the TSH cutoff greater than 2.5. Whereas if you use the normative data as estimated from that particular area, this came down to 4%. And their reference was 0.14 to 4.87 for the first trimester. So as you can see here, so they took the 2.5 to the 97.5 centile, and you can see the variation here. It goes as high as 6.28, and it's as low as 4.04. So it is actually shifting and skewing towards the right. So is it different depending on races? The answer is yes. It is going to differ depending on regions, and this is a publication which just came out a couple of weeks ago, because this is looking at a multi-ethnic population in a particular country. So this is Norway. This is obviously a Scandinavian country. This is iodine sufficient. This basically they looked at 785 pregnant women in Oslo, and they looked again at TSH, FT4, and thyroid peroxidase antibody, and they measured it twice, one at week 15 and one at 28. And they also did urine iodine concentrations. And what they found was very interesting. Now, West Asian, and they looked at a whole different people. And you had a good representation of European and South Asian population over here. And what I'd like to point out is this is a population living in the same environment. And what you have is a 2.5 to 97.5 centile in the first trimester of TSH of 0.1 to 5, whereas with South Asians, this goes to 0.01 to 5.9. As you can see, there's a clear racial difference here. So this is particularly important because we need to establish TSH pregnancy levels in India. So what are the requirements? So it is important that we calculate this based on data from healthy pregnant women. Now, how do you define them? These are people with no personal or family history of thyroid dysfunction, no visible or palpable goiter. You could do a thyroid ultrasound realistically if you really want to really quantify this. There's no history of thyroid disease at all, an optimal iodine intake, and if possible, a urinary iodine estimation. And negative thyroid peroxidase antibody status is very important, and the reference range intervals should be the 2.55th to the 97.5th centile. So we have multiple studies done in India. So these are, different states. As you can see here, with each trimester, you have a different variable level of TSH. So in one particular study, in Delhi, you have something like 0.09 to 6.65, whereas in another place, you have something like 0.19 to 4.34, and it is very variable. So again, this is variable as per the state and as per the region. And this is why we need basically, region-specific TSHs. So if you plot the 5th and the 95th centile, you can again see that basically you have values which go up and down. The current problem for establishing a unified national TSH for pregnancy is India is a group of countries. So you obviously would need to have, a state or region-wise establishments of TSHs for pregnancy to realistically, call this basically, an appropriate, reference range. And you probably may not have a unified national TSH for pregnancy. However, based on this, an interesting, systematic review was done by my good friend, Dr. Kannan and Dr. Sriram Mahadevan, and they came up with this in this publication, IGN, in 2018. They said that the TSH values can extend up to 5 to 6 in pregnancy, and this can possibly be similar to the non-pregnant cutoffs to diagnose thyroid dysfunction. Just going with the, earlier studies we were talking about, with the Asian population being skewed more towards the right side, seeing in India. So they said basically we should probably go close in line with the recommendations from the ATA guidelines for diagnosis of hypothyroidism in pregnancy. So keeping this in mind, why did ATA suddenly move from TSH of 2.5 to 4? So they looked at particularly 19 important studies. Out of this, 5 of the 19 papers cited reported an upper limit of normal to greater than 4, but the remaining 14 did not. And the other interesting aspect was out of the 5 largest studies cited, which each included more than 5,000, only 1 reported an upper limit of normal exceeding 3.5. Remember, this was predominantly, a Western-based studies. I mean, these didn't really include a lot of Indian studies. So clearly, we would need, Indian recommendations more so for us to understand this. Now, the problems with the Indian studies so far, again, because as I mentioned, because of the vast geographical differences and ethnic differences, there's a heterogeneity in the study methodology, and there are different iodine statuses, as our previous speakers mentioned, that the iodine status is very variable. The laboratory assay methods vary in different parts of the country, and the selection for reference populations are again different. So clearly, we do need establishment of reference intervals in each region, and this is of paramount importance. Now, this actually prompted an editorial by Dr. Kalra, and he basically said, keeping all this in mind, with the 2017 recommendation, he said, maybe we should go for a middling value. So we should go to TSH of less than 3 in the first trimester and TSH of less than 3.5 in the second and third trimester. But he did add that we should be able to generate more national data to come to a final conclusion. And why did he say that? So if you actually look at the various studies, you had very variable, as I mentioned. You didn't have antibody status as mentioned. I mean, in some of the studies, you didn't have thyroid ultrasonography done in most studies. Some studies did not mention clinical assessment for goiter. The details of the kit were missing in 1 or 2. The centile cutoffs were different. The iodine sufficiency was not mentioned. Everything. So you really have a very heterogeneous cohort. So with this, we have certain consensus. Now, consensus are based on discussions with experts, and so we have decided. As per the guidelines from the ITS, the recommendations are all pregnant females should be screened at first antenatal visit by a TSH. Now, if you look at it, if we really have a pan-India study, this particular study probably is pan-India. This basically was a study in 2016, but this actually included 11 cities and 9 states from India. And if you look at the cutoffs, if you were to use a very stringent cutoff of T of 2.5 or 3, you had more work. You would actually classify close to 44.5% of people in the first trimester as having hypothyroidism. And if you take a stringent cutoff of greater than 4, this comes down to 15. So you can see basically this is a lot of work in our country. And is this really essential is a question. The other important aspect is the thyroid peroxidase antibody. This obviously is going to be variable depending on the region again, but again, in this particular study, they cited 18 to 23% of pregnant women having variable thyroid peroxidase antibodies across the various trimesters. So with that, I move on to what should we treat. So I've just given you the background of what we have in terms of recommendations and why this confusion in relation to one particular society saying one and another particular society saying another. So what should we treat? So the ITS and FOXI 2019 have recommended the management of thyroid dysfunction pregnancy is based on the trimester-specific TSH cutoffs they have recommended. That is the first trimester of 2.5 and the second and third trimester of 3. This was the cutoff which they've guided. If you look at the 2017 ATA guidelines, this basically is based on the strong evidence and mild and moderate evidence and maybe small evidence. One thing is very clear. So if you have TSH of greater than 10, irrespective of whether you have antibody, thyroid peroxidase antibody positive or negative, you ought to treat. It is very clear. If you have a TSH of greater than 4 with an antibody which is positive, that means this would progress. So you have moderate evidence to treat this particular person. If you have a TSH of greater than 4 and you have TPO antibody which is negative, you could consider treatment. There is only a low evidence here. So there is no clear-cut evidence to say that you should definitely treat. Now, in terms of TSH between 2.5 to 4, if they are TPO antibody positive, and depending on who they are, like as Dr. Karthik mentioned, if they are, if they basically had some form of fertility treatment, etc., they become even more important. You basically have a moderate evidence to consider treatment. And if you have a TSH of less than 4 and they are TPO antibody negative, the ATA says there's a strong evidence of not to treat. So if you ought to treat, how do you go about it? With overt hypothyroidism, you could go for a full replacement dose of 1.6 to 2 mics per kilogram per day, and then you adjust based on TSH levels 4 to 6 weeks. You could do a free T4, but predominantly TSH. If the 4 to 10, if they are 4 to 10, you could use a close to full replacement dose. And if basically this is associated with a normal free T4, you could use an intermediate dose of close to 0.8 to 1 micrograms per kilogram per day. And if it's 2.6 to 4, and if a decision has been made to treat, you ought to start low. You start something like 25 to start with, and you up titrate further. So the TSH target in this particular subset in hypothyroidism is below 2.5 wherever possible. So what about the subclinical hypothyroidism in pregnancy along with thyroid antibody status? Now, is this really different? Now, we do know that subclinical hypothyroidism in pregnancy needs to be treated for certain reasons. We know there is an association of subclinical hypothyroidism being associated with pregnancy losses, preterm labor, gestational hypertension, preeclampsia, etc. But there's not a lot of hard evidence to say by treating this, you reverse all this. There is definitely some evidence though. So this particular paper, which was published in JCNM, was basically looking at people, treating people of TSH greater than 4 and TPO negative, and also another group with TSH 2.4 with TPO negative. What it found was if you treated the people with a TSH of greater than 4, you had a significantly lower rate of preterm delivery in the levothyroxine treated arm in comparison to the ones who did not receive treatment. And systematic review and meta-analyses has also shown that you possibly have an advantage in terms of reduction of preterm birth and pregnancy losses. So if you look across again, if you look at the overview of effects of thyroxine on treatment in terms of miscarriages, again, there is some evidence to suggest that it possibly does help by bringing the TSH low in terms of this subset. Now, what about neurocognitive issues and neuropsychological developments of the child? Now, this landmark paper in the NEJM in 1999 that Haddow et al. Basically looked at, TSH which was stored in pregnant women, and they followed up children for a long period of time, and they looked at TSH levels during pregnancy, and what they showed was an untreated hypothyroidism in pregnancy resulted in lower IQ scores of the children, and basically that was an important reason why the issue of thyroid treatment and neurocognitive psychological developments actually came across. But it is important to understand this paper had TSH values of 8 or greater, and majority were greater than 10. Then came the Casey paper in 2017, and this was pretty interesting. So they had 2 placebo-controlled trials in this particular paper. One was a subclinical hypothyroidism defined as normal free T4 and TSH between 4 to 10. And the other one was hypothyroxinemia, defined as a free T4 of less than 0.86 nanogram per deciliter and TSH of between 0.08 to 3.99. And what they showed was they actually started treating people only after week 8. And this was one of the issues with this paper, that the treatment was a little bit late. And this basically, they treated these individuals and they followed the cognitive outcomes in children through 5 years. And what they found was that there was no difference in treating these children in terms of neurocognitive and neuropsychological outcomes. But remember, the treatment started after 8 weeks and predominantly after 10 to 12 weeks in this subset. So what about thyroxine in subclinical hypothyroid pregnancies? We spoke about this. So just to put this in perspective, TPO antibody positive women with TSH concentrations greater than 2.5, you treat. TPO antibody negative women with TSH concentration greater than 4, you treat. So what about TPO? Now, when we're talking about TSH, the question always arises, what about TPO? Now, if the ATA says if you have a TSH concentration of greater than 2.5, you should consider evaluation of TPO antibody status. As Dr. Sridhar mentioned, basically, TPO is a little bit of an etiological assessment. And in terms of pregnancy, it has other connotations also in terms of association with preterm pregnancy, with terms of pregnancy losses, etc. What about someone who's euthyroid but TPO positive? Now, it is important that these people can progress to overt hypothyroid in pregnancy, and these people must have a measurement of TSH serially up until mid-pregnancy, when after that, predominantly, they don't progress. What about using thyroxine in this euthyroid TPO positive pregnancy? Now, this, again, there's very low quality evidence in relation to this, but however, if someone is TPO antibody positive, is euthyroid with a prior history of pregnancy loss, it may be considered that you could give thyroxine given its potential benefits in comparison to its minimum risk. And in such cases, you start with a low dose of something like 25 micrograms as a starting dose. So with all this in background, so I would summarize as TSH in pregnancy, what is normal now? Now, it depends on who you ask. Now, if you ask the ATA says a TSH reference limit of greater than 4. Now, if you look at European Thyroid Association, they stick with 2.5 and 3, and our own ITS guidelines, again, stick with 2.5 to 3. Now, whatever you're taking, it is important you understand that you look at the risk factors in terms of progression when you're actually using a particular guideline. And what should we treat? It is very important that we manage an overt hypothyroidism appropriately. A TSH greater than 10, irrespective of antibody positive or negative, must be treated. TSH greater than 4 basically needs to be considered as for treatment. And it is important that we regularly monitor TSH when we're uptitrating these people. So in terms of what after, so they're postpartum. So post-delivery, the patient should be reverted back to the pre-pregnancy dosages if they were already on thyroxine prior to pregnancy, and the TSH level should be checked again after 6 weeks. In terms of people who are newly diagnosed to have hypothyroidism in pregnancy, if the total dose was less than 50 micrograms, the highest was less than 50 during the course of pregnancy, you could consider discontinuing it, but it is important that you evaluate them again after 6 weeks. And then if they've had autoimmunity, we would need to consider that there is a chance that they could progress into overt hypothyroidism over a period of 5 to 10 years. So an annual monitoring of TSH and thyroid function is important. So I started off with this. So TSH, yes, what is normal TSH, and what do you treat? It is basically an art, is what I said. The study of the science of the art and the art of the science is always important to understand, to appropriately manage. Thank you very much.
Thank you very much. We had 3 excellent talks, very good discussion. I want to see one question in the chat box. So to start the discussion, first one talk by Dr. Karthik, you were talking about selenium and thyroid antibodies. And since we are attaching so much of importance to thyroid antibodies, do you think that we are also therapy? Because not only do you have autoimmunity at the thyroid level, you could also have it at the ovarian level.
I'm sorry, sir. There was some audio disturbance.
Okay, I'll just repeat it. You talked about selenium being able to reduce the thyroid antibody level, and since we have autoimmunity only at the thyroid positive level, so there be a thyroid having selenium in individual bodies positive.
Yes, sir. Some studies have looked at selenium supplementation and reduction in anti-TPO and anti-TG antibody levels. Unfortunately, these studies could not show improvement in outcomes as such. So all that could be seen was a reduction in the antibody levels pre and post treatment. Secondly, we have no standardized assays for selenium, and over treatment with selenium can have potential side effects. So as a therapeutic supplementation, selenium may not be an ideal thing to give. However, the foods that are rich in selenium or otherwise foods that are healthy and taken in pregnancy. Interestingly, I found that the highest natural source of selenium is an Indian jackfruit seed, or palakotai, what we call it. So that is considered as one of the highest or strongest natural sources of selenium for vegetarians. Otherwise, it is found in eggs, fish, and other foodstuffs. So those things should be safe to take, but pharmacological supplementation would be a little problem.
A question to Dr. Sridhar. You mentioned that TSH levels do change over the day. It's lowest in the afternoon, and post midnight it increases. With a wide variations of assays available, sensitive of the assays done, would you look at least more than one TSH reading before taking a decision? Because treating numbers, just looking at a TSH number would be, not alone enough. And would you like to combine T4 and TSH always? Would you look at, range of T4 also before interpreting the TSH levels?
Yeah, if more than one test is available, it will always will give more confident whether to treat or not to treat. And regarding the timing of sample, there is no robust studies are available, but whatever evidences and literatures is available, I just mentioned. But even though even guidelines also, there is no clear-cut consensus when to take the sample. In mild cases only, this timing of sample will be more important rather than the severe cases. Severe cases, anyway, we may able to pick up whatever time we do the TSH estimations. And so always the two tests will be better, and to assess the severity also, and the correlations also, in additions to the TSH, either free T4 or total T4 may be a better options.
And to Dr. Anand Kumar Annamalai, 3 of the Indian studies have shown that the TSH values are much higher than in Indians compared to Caucasians, even though, it was from different regions. And, you talked about iron status. Would you think that, we should now seriously consider changing off the cutoff from 2.5, 3.5, at least to 3.5 or 4?
So that's a very good question, sir. So I think if you ask me personally, I definitely would think so. Because basically, that's why I portrayed a study from the Norwegian region, also looking at specifically South Asians, and South Asians predominantly, we had people from South India. So I think it is still region specific. It may be different in different parts of the country, but increasingly more so, I think Asians and South Asians and Southeast Asians probably have a skew towards the right hand side. But however, I think we would definitely need more data. So in terms of when we get to that, but I agree. I think we probably have to shift TSH value higher, is what I would think, because I'm not sure whether by treating the 2.5s to 3s or 3.5s, we are achieving a lot of good beneficial outcomes. I mean, we don't have outcome trials for that either. But generally, it is looking more so that this is skewing to the right. And we, as you say, it's basically we do have studies with TSHs, up to 97.5 centiles, close to even 4.56.
And of course, all the speakers emphasize that you should take a holistic view of the clinical picture before you interpret the value and not just look at the numbers. Dr. Krishna has a question. The JAMA last week came with a stinging condemnation of overtreatment of mild TSH elevation, even questioned why TPO elevation should be treated. Your opinions?
That is a very interesting question, sir. As Dr. Anand Kumar pointed out, what is normal itself is a highly controversial thing. And I would like to take this opportunity to thank ESTN for this grant that we have received last week to find out what is normal TSH cutoffs in first trimester pregnancy in Tamil ethnicity women. So that should hopefully throw some light, because we are studying a large number of women, and that should throw some light. The way I think of it is we need to look at it in 3 levels. What is normal TSH in the first trimester, given that second and third trimesters have slightly lower TSH than normal? The next question is what is normal in second and third trimester? And the third level is seeing, instead of looking at statistical definitions of 2.5 centile to 97.5 centile, at what point of TSH does it become harmful to the mother, and at what point of TSH does it become harmful to the baby? Harmful defined as any bad outcome that we might care about. So if we answer these questions, then again,
good luck.
It would be difficult to say which is normal in this country. But I really agree with Krishna sir's question that even mild TSH elevation, especially TPO positivity, treating TPO positivity with thyroxine may not yield any significant outcomes.
Yeah. And good luck with your study, and hopefully in the time to come, you will be able to guide us better into treatment. I think the message which comes from all these talks is you have to take a holistic picture. You just don't interpret numbers And it's always much better if you could combine T4 with TSH and of course antibodies. And a holistic picture is taken into consideration, the clinical picture, and so many interference which could occur. And possibly when in doubt, you could even repeat the assays. We have a whole lot of assays done by different laboratories in different parts of the country or even the state, and the sensitivity also differs. I think we had an excellent session. All the three speakers did an excellent job and communicated what was to be done for these three subjects. I now hand the session back over to the organizer.
Dr. Joshi.
Thank you, sir, and thank you very much, Dr. Murthy, for moderating the symposia part, and thank you to the three speakers for taking us through TSH and aspects of fertility. So now moving on to the next aspect. So the topic which we'll be discussing is type 2 diabetes mellitus and thyroid dysfunction. And basically, we'll be focusing what the RSSDI guidelines say for that. And for this particular chapter, we have Dr. Sridhar with us, who will be moderating. And Dr. Sridhar is the head of department for the Department of Diabetes and Endocrinology in MIOT International in Chennai. Over to you, sir.
I thank Clinic and especially Dr. Krishna Sheshadri for giving me this very nice opportunity. And up to now, we have witnessed to an excellent session in thyroid disease where I personally learned a lot. Now we move over to another topic about two cousins who commonly attack together, like a double-barrel gun. Diabetes and thyroid disease. And thyroid disease is much more common in diabetics, and diabetes also should be looked for more often in a patient with hypothyroidism or hyperthyroidism. And it may, the thyroid disease may alter the course of diabetes, and diabetes again can cause some changes in the treatment of thyroid disease, be it hypothyroidism or hyperthyroidism. Be it in hypothyroidism, you can get more often, you get low sugar states where there can be more prone for cardiovascular disease. Diabetes already is exposed to that, and having coexistent thyroid disease can cause more problems. It can cause various more forms of dyslipidemia. So the RSSDI in its role has given specific guidelines for management of thyroid disease in type 2 diabetes. And to tell us more about that is none other than Dr. Jayashree Gopal, who is an MBBS diplomate in the American Board for Internal Medicine and Endocrinology. She is at present the director of Diabendo India, a senior consultant endocrinologist and diabetologist in Apollo Hospital, associate dean for teaching and research in the Diabetes Research Center in Raipur. Without further ado, it's over to Dr. Jayashree.
Thank you very much, Dr. Sridhar. I'm just putting up my slides. Yeah, and thanks to Krishna and thanks to the organizers. I think all of us have enjoyed that extremely sumptuous spread for dinner. And if those who haven't, I can tell you that it's really very nice. So I'll be quick so that we can get to bed. These are some of the topics I'll be discussing very quickly. What is the evidence that thyroid and diabetes, like Dr. Sridhar said, what is the evidence that people with diabetes are more prone to thyroid? And so what does the study show regarding prevalence rates? Why might the two influence each other? Dr. Sridhar did say they were cousins, but why exactly should they influence each other? And what are the clinical implications? And finally, I'll finish up with a quick focus on the RSSDI guidelines. So if you look at the prevalence, of course, thyroid disorders are very common. And some studies have suggested that the prevalence of hypothyroidism in India is close to about 11%, compared with much lesser numbers in certain other countries. Whether this is related to iodine supply, iodination of salt, we do not know what the reason is, or just the general increased rate of inflammation seen in our country due to other reasons, we do not know. If you look specifically at the prevalence of thyroid disorders and diabetes, this is sort of a snapshot of it. There were several studies done over the years with varying number of patients, but in all of them, you can see that whether we just define it as hypothyroidism alone or thyroid dysfunction, the rates tend to vary from around 20% across all studies. And you can see that in the control population, it is around 5 to 8% in the few studies that looked at it. So almost about 2 to 3 times the prevalence in the non-diabetic population seems to be there in people with diabetes. About nearly 20%, 1 in 5 of them tend to have a thyroid dysfunction, higher than the population without diabetes. So definitely there is an increased prevalence. Now, is there any way we can predict if a person with diabetes is more prone for developing hypothyroidism? And this was an interesting study published a couple of years ago, where they looked at what were the clinical factors associated with the presence of hypothyroidism in people with type 2 diabetes. And in this study, clinical hypo was found in about 10% and subclinical in about 6%. And these were the factors that predicted the prevalence of thyroid dysfunction: longer duration of diabetes, hypertension, dyslipidemia, presence of anemia, interestingly, or being overweight or obese. Of course, the previous talks, Dr. Sridhar's talk touched upon the association between BMI and TSH. So it is not surprising that if we use a TSH to diagnose or determine if there is some overactivity, underactivity of the thyroid gland, that it may look like some people with diabetes have hypothyroidism. Another study, which was done in a different part of the world, also showed some, again, common factors. Of course, female gender. So more people with diabetes who are women tend to have thyroid problems, which is not surprising. Family history of thyroid disease as expected. Again, this one thing stood out: the duration of diabetes, in this case, more than 10 years. So I think similar sort of things are beginning to emerge. Longer the duration of diabetes, higher the BMI, definitely family history. I just go back to this. Presence of hypertension and dyslipidemia. Now, why may this be? What is the reason why all of these so-called metabolic syndrome factors also seem to be associated with thyroid dysfunction? And of course, similar results, we are all aware of the association of thyroid disorders in people with type 1 diabetes. And this may be related more to an autoimmune type phenomenon. So the prevalence of positive anti-TPO antibodies and TSH and TSH elevation hypothyroidism warrants a periodic screening for thyroid function in people with type 1 diabetes. So moving on to the question about why they may influence each other, I want to talk a little bit about the effect of thyroid hormones on metabolism in general, but also a word about how medications can affect thyroid function, and about how medications that we use for diabetes can affect also the certain thyroid-related complications, and also interpretation of blood tests while on certain diabetes medications. So one very simplistic way to look at it is that both thyroid dysfunction and diabetes is caused by a hyperinflammatory state. We are all aware of the fact that diabetes causes most of its complications because of the excess inflammation associated with it. And therefore, it may not be surprising to speculate that the same inflammation is also having an adverse effect upon the thyroid gland and causing it to malfunction. And of course, this one paper also posited that maybe an altered deiodinase activity was also involved. And but it explains why people who have a longer duration of diabetes are more prone to a thyroid problem. And this is sort of looking at it in the reverse way: the effect of thyroid hormones on various enzymes involved with metabolism, with all of these sort of, whether it's a carbohydrate, fat, or protein metabolism. I'm not going to read this out one by one. I just want to go to this one slide, which shows what is ultimately the effect of thyroid hormones on glucose homeostasis. So if you look at the GI tract, thyroid hormones help in increasing glucose absorption. If you take the liver, it increases hepatic gluconeogenesis. In the adipose tissue, it increases lipolysis. Skeletal muscle, it improves sensitivity, increases glucose uptake. In the pancreatic beta cells, it helps to improve insulin secretion. And in the alpha cells, it helps to also increase glucagon secretion. So as you can imagine, some of these effects tend to increase the glucose and some of these effects tend to decrease the glucose. So the balance depends upon what is the actual level of thyroid hormone that is prevalent. But definitely thyroid hormone, maintaining a euthyroid status has an important part in controlling also the glycemic status. So this is again a slide which is from a paper which was published in Endocrine Reviews about a couple of years ago. And they list out all of the factors, all of the changes that can occur with glucose, both in hyper and hypo. A couple of things I did want to point out. One is that in hypothyroidism, there is reduced renal insulin clearance. In general, in hypothyroidism, in severe hypothyroidism, but some people feel that even in moderate to mild hypothyroidism, there will be a tendency towards hypoglycemia. We are all aware of the association between, say, something like a myxedema, coma, and hypoglycemia, but also some experts feel that even moderate degrees of hypothyroidism can be associated with hypoglycemia, and the reverse is true. In hyperthyroidism, again, we are all very familiar with this fact that patients with hyperthyroidism sometimes present with blood sugars in the diabetic range. And once the thyroid is controlled, the sugars can come back into the normal range. So they have opposing effects upon the glycemic status. Now, moving on to, therefore, the clinical implications. Apart from the fact that it affects the glycemic status, is there any other sort of dysfunction that results from this association? Actually, an interesting paper from China looked at the associations of subclinical hypothyroidism, type 2 diabetes. This was a meta-analysis. And what they showed very interestingly was that there was a significantly increased risk for diabetic nephropathy in people with type 2 diabetes who also had subclinical hypothyroidism. And you can see that that most of the studies have shown a clear increase in risk. And not only are they showing an increase in risk, also studies have shown, some of the studies have shown that if you treat the subclinical hypothyroidism, the parameters of diabetic nephropathy reverse. In other words, where the proteinuria comes back and the eGFR improves. So this is one thing we need to keep in mind. That definitely the subclinical hypothyroidism itself can increase the risk of nephropathy, potentially reversible nephropathy with diabetes. There may be a tendency towards a slightly increased risk of retinopathy also, though the association is not as strong as with nephropathy. And similar data is seen also for neuropathy. Therefore, all the three microvascular complications, strongest for nephro, but a tendency towards maybe an increased risk also for retino and neuropathy in type 2 diabetes with subclinical hypothyroidism. How about the macrovascular complications? Again, this is sort of easier to sort of explain and understand maybe. We are all aware that hypothyroidism, subclinical hypothyroidism increases certain parameters that increases cardiovascular disease risk, particularly through its effects on, say, the left ventricular dynamics and through dyslipidemia. And therefore, studies have shown interdependent associations between the thyroid status, insulin resistance, and dyslipidemia. Now, there was an interesting paper published where they looked at the TSH levels and the risk of coronary heart disease in people with type 2 diabetes. And even TSH levels within the reference range had a linear and positive association with the presence of coronary events. In other words, in a diabetic population, the higher your TSH, the higher your chances of having a coronary event. However, this did not translate into the risk of new onset atrial fibrillation and all-cause mortality. Of course, this is from a relatively small database, but maybe more studies will come out in the future, giving us more, this very intriguing piece of hypothesis that the higher the TSH in people with type 2 diabetes, higher the chances of cardiovascular events may be related to a subclinical hypothyroidism, which then increases the risk of a cardiovascular event. And I also wanted to mention the effect of anti-diabetic drugs in coexisting diabetes and thyroid disorders. One of the things, of course, is the effect of metformin in lowering TSH. We're all familiar with this. Interestingly, this effect of metformin in lowering the TSH seems to happen in TSH values which are at the upper limit of normal. One of the studies showed that it was usually in the TSH range, which is about 2.5. So in the TSH between 2.5 to 5, it is in that population that the metformin lowers the TSH. Whether the TSH gets lowered because of the weight lowering effect of the metformin is not known, but it is an association we need to keep in mind. And this is a reversible effect. After metformin is discontinued, the TSH levels tend to bounce back up. Also, metformin has been shown to reduce thyroid volume and nodule size, very interestingly. This may be related to the fact that development of goiter or thyroid nodules may be related to insulin resistance, the sort of the growth promoting effects of high levels of insulin. And maybe the metformin helps to negate that effect. The first generation sulfonylurea compounds had goitrogenic activity. Of course, we do not use them, but just to point out the association, thiazolidinedione use has been associated with an increased risk of Graves' ophthalmopathy. So we need to be cautious about initiating it in people who either have Graves' disease who are being treated for ophthalmopathy. So we need to keep this in mind if at all we are considering the use. And of course, insulin. I pointed out earlier that in hyperthyroidism, because of the hyperglycemia, insulin dose requirements may increase, and the reverse occurs in hypothyroidism, that the insulin dose requirements may decrease. So what we also need to keep in mind is that as we treat it, as the hyperthyroidism or the hypothyroidism improve, this may lead to changes in insulin requirements because of the changing glycemic status. And there is also an effect of the thyroid status just on the glycated hemoglobin. This is seen more in hypothyroidism rather than in hyper. So if you look at this, the HbA1c change following treatment of hypothyroidism. This was in euglycemic individuals with hypo and hyperthyroidism. So these were not people, they had good blood sugar control to begin with, but you can see that after treatment of the thyroid status, the HbA1cs tended to come down. Now moving on to the guideline recommendations, the various guideline associations in type 1, I think they're all fairly standard. They all say do a TSH at diagnosis and repeat thereafter every year. This is sort of fairly standard. The measurement of anti-TPO antibody, again at diagnosis, to say that if the TPO antibody is positive, then maybe you need closer monitoring. In type 2 diabetes, the guidelines are more heterogeneous. They're more sort of, they're not very standard, and I'll come to the Indian guidelines rather than going through this. So the RSSDI came out with a guideline regarding thyroid dysfunction in people with diabetes and how do we deal with it. If you look at type 1 diabetes, again, the RSSDI also says screen for anti-TPO antibodies and TSH at the time of diagnosis of type 1. And they make it a point to point out, including people who are euthyroid, young patients and males. So it is not that only female patients are more prone to thyroid disorders, and it's not just the older people. So whatever be the age, whether they are men or women, they need to have a TSH and an anti-TPO antibody. If they have a positive TPO antibody, then they need to have an annual TSH screening. If it is negative, then maybe once in 2 years. In high-risk patients, so in people in whom you're finding it difficult to control the blood sugar, so that they have high glycemic variability, or if they have a goiter, more frequent TSH screening may be necessary. This is a matter of clinical judgment, but this is what the guidelines are saying. I think at least yearly once, I think is a good option. In pregnancy, again, very important. Of course, now the guidelines say they recommend universal screening for all pregnant women. So I think this goes without saying. But if they have type 1 diabetes, the guidelines recommend that you should also screen for TPO antibodies before pregnancy, or at least during the first trimester. I think personally that a TSH is more important. I do not think the presence of a TPO antibody is going to alter my management strategy for a person, a pregnant lady or someone with type 1 diabetes. But where the TPO antibodies are helpful are to predict the occurrence of postpartum thyroiditis. So if they have a positive TPO antibody, it is recommended that at 3 and 6 and 12 months postpartum, their thyroid function should be screened. And children and adolescents, I pointed this out, they need TPO evaluation as well as TSH screening. Now, if you look at type 2, of course, yes, the thyroid disorders, daily dose of insulin can be affected by the thyroid status, and we need to keep this in mind when we are treating the thyroid. We need to keep in mind that insulin requirement may change. It may go either up or down. If you look at the guidelines on type 2 diabetes and thyroid, similar thing. For people with type 2 diabetes, TSH screening at the time of diagnosis, at least once, and then every 5 years in individuals above the age of 35 years. So this is what is recommended for the general population. The guidelines felt that routine screening is not necessary for patients with type 2, but it may be favorable depending on their clinical profile. And if they have a TSH of over 2 or a positive anti-TPO antibody, they may be considered for annual screening. Now, again, one of the talks pointed out, a very good level of TSH, whether you have optimal functioning of all of your tissues, is probably a TSH at the lower limit of normal. So anything which is nearer the upper limit, though I do not know if I would use a TSH of 2 as a cutoff, but certainly a TSH of say 3.5 or 4, I would consider more frequent screening, because this may be a person who may go on to develop a hypothyroidism. And again, similar, if you find someone with uncontrolled diabetes, and I think more than the diabetes also, dyslipidemia, difficult to manage dyslipidemia, say they're on statins, and in spite of compliance with the statins, the cholesterol is not coming down, or even hypertension, all of these situations point towards the thyroid being a possible etiological factor in this complication. So we need to keep always the thyroid in mind. If you've not checked it in the last, say, 6 months to 1 year, it has to be checked. And above the age of 65 years, so between the ages, above the age of 35 every 5 years, above the age of 65, particularly for women, a TSH screening at least annually is recommended. And I think that's reasonable, given the fact that thyroid disorders tend to become more common as we get older. And so this was in people with gestational diabetes. Again, like I said, universal screening, so this becomes moot. If they have positive TPO antibody, then you screen them at 3, 6, and 12 months. Even children with type 2 diabetes, similar screening profile. You do a TSH at baseline, do a TPO antibody. And the guidelines make it a point to say that metformin can be safely prescribed in people with diabetes and thyroid disease. And dosage of levothyroxine can be reduced when prescribed alongside metformin if reductions in TSH levels are found to be significant. Now, I think the only way to interpret this is if you're finding a persistently low TSH in someone who is on metformin, we need to keep in mind that the metformin may be a possible reason for a slight drop. You're not going to have a drop in the TSH below 0.5. Instead of having a value of, say, 1 for that person, it might come down to, say, 0.7 or 0.6. But it's unlikely to be completely suppressed. So if you see a very suppressed TSH, you have to start evaluating the possibility of thyrotoxicosis. However, if you're getting a TSH which is at the lower limit of normal, it may potentially be related to metformin. But if the free T4 is within the normal range, the person is otherwise clinically euthyroid, I do not think we need to necessarily make changes in the adjustment of the levothyroxine dosage just because the metformin has dropped the TSH level. But it is a factor to keep in mind when we are interpreting thyroid levels. Always, it comes back to what Dr. Murthy said, clinical assessment of the patient and treatment is the most important factor. So this is my final slide. These are the take-home messages. Thyroid dysfunction is common in people with type 1 diabetes. They're more due to autoimmune etiologies, and type 2 diabetes may be because of inflammation, the subclinical inflammation causing thyroid dysfunction. Periodic screening and appropriate thyroid therapy in people with diabetes may help to reduce diabetes complications. Certainly for nephropathy, it has been shown to have some improvement even in subclinical hypothyroidism, and potentially maybe also because it improves lipids and blood pressure, it may also have a role in improving cardiovascular disease outcomes. Certain diabetes medications can affect thyroid-related blood tests and complications. I spoke about the relationship between metformin and TSH, and the relationship between thiazolidinediones and thyroid-associated ophthalmopathy. And I think the most important point is anytime we have a suboptimal control of diabetes or hypertension or lipids, always consider a thyroid dysfunction as being the cause, screen for it and treat it, and you might find a good improvement in that parameter. I shall stop here and thank you very much again.
Thank you, Dr. Jayashree, for that lucid talk on these two important disorders of type 2 diabetes and hypothyroidism. Now, in the chat box, there are two questions for you. The first question says, why all patients with why all diabetic patients will not present with hypothyroidism if inflammation or other inflammatory markers will be the cause? That's how the question is going.
Yep, that's an excellent question. Obviously, if inflammation is not the only reason, why do some people develop a thyroid problem? Why is it that only 10% of the population develops a thyroid problem? Obviously, there are other factors. You have hereditary causes, you have, your HLA makeup, your predisposition to thyroid problems. So it is one of the reasons that contributes to. So another way of asking the question is, if a person who is otherwise prone to thyroid diseases, if he does not develop diabetes, will he still develop a hypothyroidism? I think that's the way we should be asking the question. I think the inflammation adds on to it. I think it adds on to his already underlying risk. He or she may develop a thyroid problem as they get older as a factor of age, but they may develop it at a younger age because of the factor of inflammation.
The next question to you is, almost all diabetic patients are on metformin as the initial course of therapy, but still hypothyroidism is not seen in all diabetics.
Metformin, I'm sorry if I
I think
clarified.
Wrongly interpreted your statement. You said metformin reduces the TSH.
Yeah, it just reduces the TSH value. It does not directly affect thyroid functioning in any way. It just reduces TSH values. So what I said was, when you interpret TSH values in a person on metformin, remember that if the TSH is low, it may be related to the metformin effect. It's just something to keep in mind. I do not want to over exaggerate. I think it is just a very academic point. But just to say that there is a little bit of a reduction, not a major reduction, but some reduction in TSH because of metformin.
My personal question, if your patient on diabetes who's reasonably well controlled, you discover hypothyroidism, will you alter the dose of the diabetic medication?
If it's, it depends on how well the diabetes is controlled. I mean, if it is a sort of, I'll have them under close follow-up. I'm not going to do it before I start the thyroid treatment, but I will warn them that if it's a hyperthyroid, I will tell them as the thyroid levels are improving, your sugars may drop. So keep a careful look for it, and vice versa for grossly hypothyroid. Grossly hypothyroid may be having artificially low sugars, and I will tell them, just watch out, your sugars may start going up. But I will not do it before the fact. Once you put them on thyroid hormone, just educate them about changes in blood sugar levels and maybe check it in about 2 to 4 weeks' time.
Have you personally seen the TZDs worsening ophthalmopathy?
Not really, because we don't use it much. But there was one lady who was on it for a long time, who also happened to have it. I mean, I had one patient, so, but it has been mentioned but I don't use TZDs much, so I do not know. How about you?
I still use a lot of TZDs. I have not certainly come across, so this was new information to me. So that's why this quick. Okay, I thank you for this lucid lecture, and I think that since there are no more questions, it's back to the organizers.
We all turn on our videos so that we can have one click to share. It's like
I can see Karthik already adjusting his hair for the photography.
I know. He has hair, I can't. So, Prem and Anand, Deepa and Ravi, you can also unlock. Anand, I think is okay. So let's get a quick pick. Ravi, thank you. Yeah, Deepa is here. Ravi. So Deepa is the person behind, who's been contacting all of you, making sure that you don't go to bed hungry and everything else. I think.
Thank you.
And especially in Chennai, I think we got, and Ravi is the one who runs this platform. So we've had over 500 people actively listening to this program today. So for a small update like ours, I think that's really nice. And you know, the quality that we've had today is just tremendous. Everyone stayed back simply because, you know, as endocrinologists, we find so much difference in the way we do things, and we learn so much from each other, and that was wonderful. So thank you, everyone. Asta, if you have any final comments to do, what I'm going to also do is request Ravi to leave this open for a few more minutes and cut off the live stream. Audience, thank you very much. Thanks for joining. I hope this was useful to you. Please leave your feedback. And what we will do is we'll also leave after the live is cut off, I will leave it on for a few minutes. So those of us who want to catch up and network, I think we will leave this on because we never get to meet as much, and especially with many people have actually had a full dinner now, so it'll be nice to